the Principal and Pro Vice Chancellor of UWI St. Augustine, Professor Brian Copeland, the Dean of Faculty of Medical Sciences, Professor Terence Simonga, colleagues and members of CPD and Outreach, our listening audience, ladies and gentlemen, it is my pleasure as the chairman of the Faculty of Medical Sciences Committee on Continuing Professional Development and Outreach to welcome you to this first visual health fair of the Faculty of Medical Sciences. The Faculty of Medical Sciences produces healthcare professionals in the areas of nursing, optometry, pharmacy, dentistry, veterinary medicine, and medicine. Therefore, the population of Trinidad and Tobago expects the faculty to champion the cause of healthcare delivery in this population. We have always met this expectation. This is the first time the committee is organizing a visual health fair, essentially because of the existing pandemic. It should also be noted that different schools and departments within the Faculty of Medical Sciences usually conduct different seasonal health webinars, conferences, and meetings that are well known in the population. But in spite of this pandemic, we in the committee strongly felt that we must stage this health fair, at least to meet the societal expectations and demand. Indeed, we are in a challenging times, and our effort within the committee is to strive to overcome the challenges. I am sure that you will appreciate the information that will be provided through the different presentations today. I, as the chairman of this committee, my duty is to thank you for your participation and to warmly welcome you to this first visual health fair of the Faculty of Medical Sciences. We appreciate your presence, and I want to thank you immensely for coming. Thank you.
Hi, good morning, everyone. And thanks, Professor Eisenmacher, for such a beautiful welcome. And we'd like to thank each and every one of you joining us here this morning. I'm Dr. Sandeep Maraj, and I'll be the chairman for proceedings going through this virtual health fair. And it's my pleasure now to introduce the Dean of the Faculty of Medical Sciences, Professor Terence Simonga, who only recently was named among the top 2% of scientists in the world, which is a significant achievement. And to know that the leadership of the faculty is in such good scientific hands, not somebody who is unknown for having a stellar contribution to the world in the field of research. Professor Simonga is a person who not only leads in the field of research, but is a very, very proficient clinician, where he was ranked in the top 10 in his field of respiratory medicine in the world as well. So with not much further ado, I would like our team to bring on Professor Terence Simonga, who will bring greetings on behalf of the Faculty of Medical Sciences. Thank you, team.
Good morning, everyone. It is my pleasure to welcome all of you here today to this health fair, which is supported by the Faculty of Medical Sciences and, importantly, our subcommittee for continuing professional development and outreach. In the past few years, we've had face-to-face, if I can use that term, fairs at the Eric William Medical Sciences Complex. But of course, this year, in view of the COVID pandemic, we are having a virtual health fair. That shouldn't prevent you in any way from getting maximal benefits, because health fairs are all about the exchange of information. So we have an emphasis on NCDs in this health fair. And the reason is very simple. Regardless of what happens with COVID, NCDs remains the major cause of death. And by NCDs, I mean the non-communicable diseases. Even amongst COVID patients, the major association with COVID deaths is still non-communicable diseases. In one press release from the Centers for Disease Control in the United States, they said that 75% of their deaths are associated with 4 or more comorbidities. So it is good. The program is going to be kicked off by the director of the School of Nursing, Dr. Ocho, who will talk about calories. And then we will have Professor Tilak Singh, one of our outstanding academics, who will talk about the management of NCDs in the pandemic. We are not going to forget the important contributions that oral health makes to our general health, and Dr. Ramu will talk a bit about that. After the break, we'll talk about medications. That's very important. Drug interactions and the side effects of drugs are very, very important. And many of us overlook it. And I'm very, very pleased to see we have staff from the School of Pharmacy, but also our own Dr. Beryl Simmons, who has been with us for a very long time, a very, very well-respected colleague in the faculty. He's retired, but he's come back to us, and he's going to talk a bit about managing chemicals in the home. And with regard to our drug interactions and adverse events, it will be Dr. Ignacio and Dr. Extavo. It is a great pleasure for me to recognize the contributions of Professor Emeritus, Professor Vijay Narayan Singh, who will educate us on the diabetic foot. Professor Narayan Singh for years has been our leading vascular surgeon in this country, actually, as well as in the University of the West Indies. And he will be supported by the staff of the School of Nursing again, who will talk about the nursing care of the diabetic foot. And Professor Yuri Clement will conclude that section on diabetes by looking at herbal medicines. Herbal medicines are a very, very important part of the primary care of patients. A lot of patients prefer to use herbal medicines before they move on to prescription medicines. And we must always remember that our prescription drugs, the root, if I could use that term, of all of them, is in fact herbal medicine or plants. We will, however, close with a roundup on the pandemic with another outstanding academic, Professor Christopher Ora, talking about the future, and our own Dr. Satish Sakamuri talking about the detection of COVID-19 and its prevention. And very important, closing off with the mental issues being faced during the pandemic. So in all, I think you will agree with me, we have a well-rounded program. Some very experienced academics and opinion leaders will be presenting to you. I hope that you use this opportunity to benefit greatly from them, and feel free to tax them as much as you wish with your questions. It's my pleasure to declare today's session open and to invite all of you to really have an enjoyable session with my colleagues. I thank you very much. Good day, ladies and gentlemen.
And thank you very much, Professor Simangal. As you would have heard, he had introduced our entire program, so there's no job for me. But most importantly, just to let you know, this program, this health fair, is one that is fun. It's one for you to relax and one for you to enjoy. We do hope that you stay the day with us. And more importantly, it's for you to be educated. And in that regard, we'll have a number of giveaways going forward. After Professor Simangal, we now are very, very delighted to bring forward the leader of our university, the person who charts the course for the university going forward, and the person who is given a vision and has delivered on the vision over the last 5 years during his tenure, one of putting education at the forefront, as he has always said, of making sure we have transformation in Trinidad and Tobago. And I do wish now to invite Professor Brian Copeland, the principal of our campus, to address you. I now pass over to Professor Copeland. Good morning.
Terence Simangal, Dean of the Faculty of Medical Sciences, other distinguished colleagues from the Faculty of Medical Sciences, other distinguished guests, members of the media, ladies and gentlemen, good morning all. It is a pleasure for me to provide a few remarks at this virtual health fair mounted by our Faculty of Medical Sciences. Because of other commitments, however, I do regret having to bring these remarks on a virtual, but albeit asynchronous fashion through this pre-recorded message. When I took on the responsibility of St. Augustine Campus Principal in 2016, I engaged in a bit of introspection by asking my colleagues what would appear to be, to many, be a very, very trivial question. And that is, what exactly is the purpose of education? Now, as expected, I received a host of answers, ranging from preparation for the workforce and a decent standard of living to self-enlightenment. All excellent answers and all invariably in line with traditional thinking. But the one answer that resonated with me was that the raison d'etre for education is to enable citizens to survive in the face of existential challenges and to thrive as opportunities so permit. Indeed, from the very earliest of times, long before formal education systems came to be, knowledge has been passed on from one generation to the next to ensure the very survival of the species. In keeping with this rationale, we at the UWI have seriously embraced our responsibility as a stakeholder in the challenge of optimally preparing citizens to survive and thrive in the best and worst of times. This can only be ultimately achieved if, inter alia, our citizens are in the best possible physical and mental health through every stage of their God-given life. However, despite the tremendous advances in medicine and given the inordinately complex nature of human biology and physiology, we still fall far short of the mastery of the knowledge required to achieve this goal. It is for this reason that we must be unrelenting in the conduct of medical research and why discussions on the range of topics to be presented at this virtual health fair are also important. COVID-19 has amplified not just the importance of the discourse, but also the need to more effectively lift the knowledge of our fellow citizens on the importance of understanding their bodies and minds, and to ensure, in so doing, that they are well seized of all that is necessary to maintain excellent health. In short, we must build a more physically and mentally literate citizenry. Much has been done in the past few years, but given the ravages of this pandemic, much more needs to be done. I'm so very pleased, therefore, to see that various experts will present informed advice, research, and data leading to public and mental health. If I were to make one suggestion, it would be for us to follow up by engaging the education and health authorities on an enhanced school curriculum that targets the strengthening of the mentally and physically literate population of which I spoke. It needs to be well embedded, deeply embedded in our culture. On behalf of the St. Augustine campus of the University of the West Indies, I wish all of you a productive and collaborative day. Thank you.
Thank you very much, Professor Copeland. This morning, we are very, very, very happy to note that we have over 250 participants at the moment. And soon, as the day goes along, there will be giveaways. And the first giveaway we like to give this morning, and I would like Miss, well, I'm hoping it's Miss Sadia Aitkens. I hope I pronounced it correctly. You would have been awarded, for the first person that commented on the chat this morning, a $200 voucher by Massey Food Stores. So Ms. Aitkens, Ms. Amrika Ramdas will be reaching out to you via the chat to get your information. Just to let you know how the day is going to go on, we'll be having presentations, the first group, as you said, with CNCDs, and thereafter, we have the big prize at the end of the day. For those who would have stayed with us and throughout the day and correctly answer the questions in the last session, you stay through the day. So we have your time stamped, by the way, for as participants. So if you would have stayed with us throughout the day and answered the questions in the last session correctly, there is the possibility, not the possibility, there is a trip for 2 to Tobago and 2 nights at Le Grand Color Hotel. And we like to thank Le Grand Color Hotel for sponsoring this wonderful prize and pushing to ensure healthcare education happens in this country, because an educated, as the principal said, educated and well-informed person, and I see a question, what time the health fair is going to end? It's not going to be a long one. It's just at 1 p.m. today. So we want persons to stay with us. You'll be able to make a better decision. And therefore, going forward, we wish to start off with our CNCD section, and our friends from Food and Nutrition, Ms. Rosette Stout, and a team has developed a fantastic presentation on fitness and healthy eating. And we have to thank Dr. Ocho and his team. We have to thank Dr. Ocho and his team for working with them to ensure we have this presentation this morning. So I pass over to our team out of Food and Nutrition. Good morning again.
Greetings to the Honorable Minister of Health, Mr. Terence Yalsing, Chairman, specially invited guests, and to the general public in attendance at this year's University of the West Indies Virtual Health Fair. Healthy New Year to you. As the new year approaches, many of us may have taken on the mantra of New Year, New Me, with intentions of committing to a new diet and fitness plan. Sounds familiar? Raise your virtual hand if you've been there and done that, or if you're presently there. With this in mind, and with the aim of bringing healthcare closer to you, I, Rosette Scotland, a dietetic intern at the University of the West Indies, alongside my fellow interns Ms. Janicia Pemberton and Ms. Orvian London, will be presenting on a few key principles of healthy eating and fitness as we start the new year. Resolutions to exercise more or generally improve fitness and diet are common during this time of year. Even more so since the start of the COVID-19 era, health and wellness has become top priority to kickstart the new year. Despite this, however, the success rate of these resolutions is often low, with 80% of diet and fitness resolutions failing by February, according to Dr. Alona Pulde. The low success rate of healthy eating and fitness resolutions is no secret, however, as more and more individuals who are hoping to adopt a healthier lifestyle tend to fall victim to fad diets. These diet plans are advertised as the fastest and easiest way to achieve weight loss. However, they often involve the elimination of foods which are rich in essential nutrients for the maintenance of good health. Such diets limit your nutritional intake, can be unhealthy, and tend to fail in the long run. One of the first steps on a healthy journey should be to understand what wellness and healthy eating entails. So, what is wellness? Wellness is a lifelong journey through which people develop an awareness of and make positive choices about their behaviors, lifestyle, and activities that enable them to lead their best lives. This journey is one that is personal and multidimensional. As a result, several factors contribute to one's state of wellness. These include diet, activity level, stress level, sleep, social relationships, management of coexisting medical conditions such as hypertension or obesity, and lastly, healthy lifestyle choices. Healthy eating, therefore, is a key component of wellness. To some of you, healthy eating may look like this. Or even this. However, healthy eating should feature a variety of foods rich in nutrients to support your growth and development, helping you to achieve and maintain a healthy body weight, prevent nutrient deficiencies, and reduce the risk of chronic disease across your lifespan. In Trinidad and Tobago, non-communicable diseases such as heart disease, stroke, cancer, diabetes, and lung disease account for 62% of deaths every year, with 3/4 occurring in people under the age of 70. Deaths due to non-communicable diseases can have adverse effects on the health and livelihoods of individuals, which in turn has negative impacts on families and communities. 4 major risk factors in non-communicable disease risk include tobacco use, alcohol abuse, physical inactivity, and unhealthy diets. Research, according to the Pan American Health Organization, shows that over half of the population has at least 3 risk factors for non-communicable diseases. Yet many people still experience difficulties in adopting healthier lifestyle practices. It is therefore important to understand that good nutrition is really about having a well-rounded diet, and it's easier to do than you may think. In fact, living a nutritious lifestyle can be attainable and fun with the use of a few simple building blocks.
Fitness and a healthy diet relies on the building blocks such as balance, variety, and moderation. It is essential to balance the food that we eat. For example, we can't have high consumption of processed foods such as fries, cakes, and burgers versus the low consumption of vegetables, fiber, and fruits. Ensure to balance. Consume the right amount of nutrients and to not consume one nutrient in excess of another. Variety is an essential concept that we must remember. Regularly consume different foods from different food groups in order to obtain optimum nutrition. A variety of physical activities may also be incorporated into one's fitness routine to build strength through walking, jogging, push-ups, as well as flexibility and balance through stretching and yoga. One must not forget moderation, that is, to not overeat or undereat. Eating with moderation must be practiced by monitoring the portion size of foods. The practice of regular physical activity should also be maintained in order to control the calories that we eat and to maintain optimum weight. As such, the energy that we consume must match the energy that we expend. A simple technique that may be used going forward in order to create a healthy eating routine is by following the My Plate Food Guide. The key features of My Plate Food Planner allows you to portion the meals in order to create a balanced diet from a wide variety of foods, utilizing the 6 Caribbean food groups, which includes vegetables, fruits, foods from animals, fats and oils, legumes, and staples. The portion sizing for My Plate allows for half of your plate consisting of vegetables, a quarter of lean meats, a quarter of starchy foods, 1 serving of fruits, along with the use of plant oils such as olive oil at preparation or while serving, and a glass of water as the main beverage. Tips: breakfast options may comprise of only half of the plate, consisting of staples, foods from animals, fruits, and the option of vegetables, while the main meals such as lunch and dinner may comprise of the whole plate, where half of the plate is primarily vegetables, and the other consisting of food from animals, staples, and the option of fruits. You may also come up with creative snack ideas with the use of staples or fruits instead of cakes and pastries. Whole fruits such as apples contain all natural fiber. Fruits provide a great source of dietary fiber, antioxidants, vitamins, and minerals. 400 grams a day can help us to stay healthy. A guide has been provided when judging portion sizes, where staples, legumes, and fruits would be an amount the size of your fist, vegetables as much as you could hold in both hands, food from animals the size of the palm of one's hand and as thick as the little finger, while fats and oils are limited to the size of your thumb.
Physical activity, in its most basic form, can be defined by the World Health Organization as any bodily movement produced by skeletal muscles that require energy expenditure. So simply walking up the stairs, participating in household chores, or even tending to your garden are all forms of physical activity. Exercise is seen as a more deliberate subcategory of physical activity, which is planned, structured, repetitive, and purposeful, as its primary aim is to maintain or improve various elements of physical fitness. So, while both physical activity and exercise can lead to development of physical fitness, these 3 terms all encompass various meanings and should be evaluated before embarking on a fitness journey. While we may have found our physical activity journey difficult in the past, the recent COVID-19 pandemic has also been an additional barrier in achieving our various goals. Studies have attributed the decrease in physical activity during the pandemic to an increase in anxiety and depression, whereas other studies indicate the decrease has been linked to the various lockdown and social distancing restrictions, largely in part due to the working from home mandates implemented worldwide. While physical activity has been on the decline, engaging in physical activity has been shown to have a tremendous impact on coping with the mental and physical strains of the pandemic. Physical activity, as mentioned before, doesn't have to involve structured exercises, but incorporation of additional movement to your daily life. Activities can be simple and fun movements that get you moving and get your heart rate pumping. If it gets you slightly out of breath and a bit sweaty, it's working. This can involve activities such as family playtime, household chores, walking your dog, or even going for a 20-minute jog around your village. You can even include more structured forms of exercise, like online classes with a personal trainer, free fitness apps, or A 30-day skipping or jumping jack challenge is a great way to incorporate movement and increase your level of physical activity. While it is recommended that adults receive 150 minutes of moderate activity a week, starting off small with at least 15 minutes twice a day and building your way up is a much more sustainable way of encouraging and achieving your fitness goals at the end of the year.
Take the first step by consulting a dietitian and a certified physical trainer in order to develop the best fitness regimen and a personalized meal plan to adequately achieve healthy weight goals and to establish healthy eating habits. It is important to note that dietitians are trained professionals certified to provide information and practical advice related to nutrition based on evidence-based practice. They are capable of providing dietary counseling, dietary therapy, and clinical nutrition therapy, while nutritionists are only qualified to conduct nutrition research, provide nutrition education, and public health and community nutrition. Personal trainers possess the practical and scientific background on the fundamental principles of the science of exercise and have the capabilities of designing and executing fitness programs specific to achieving the needs of individuals and their fitness goals. Nutrition and exercise go hand in hand in order to maintain a healthy diet and to live a healthful lifestyle. You're well on your way to adapting a healthy lifestyle when you add a healthy diet and appropriate fitness regime to your New Year's resolutions list.
To a new year and a healthier you. Remember, it's not a diet, it's a lifestyle change.
And I wish to thank our colleagues, as you see, from the nursing school and those from the Department of Food and Nutrition for putting together such a fantastic presentation. I see some fantastic questions being asked, and just at the end of this session, we'll address them as we deal with CNCDs and diabetes. I will now like to, however, introduce our colleague, Dr. Visha Ramrup, lecturer, School of Dentistry, who will be doing a fantastic lecture, something that people ignore and people don't take much attention to, which is oral hygiene in the chronic disease patient and why oral hygiene is important. So what I will do, I will now pass over to Dr. Ramrup, and please keep putting your questions in the chat. I have Ms. Ramdas getting them together, and we'll make sure and ensure that your questions are answered at the end of this presentation section. Thank you.
Good day, everyone. My name is Dr. Visha Ramrup, and I'm a lecturer at the School of Dentistry. And this morning, I want to talk to you all a little bit about oral health and non-communicable diseases. So what are non-communicable diseases, or NCDs as they are more commonly known? NCDs are chronic diseases, and the main types of NCDs are cardiovascular diseases, such as heart attacks and strokes, cancers, chronic respiratory diseases, and those would be things like COPD and asthma, and one which we're very familiar with here in Trinidad, diabetes. What we also know coming out of research is that NCDs are a major problem worldwide. In fact, they kill almost 41 million people globally each year. We also know that they don't affect everyone in the same way. And they tend to affect people in low and middle income countries. So that would be like countries like Trinidad. They tend to affect us more. And it's in countries like this that more than 3/4 of the global NCD deaths occur. We also know that the 4 diseases we mentioned before, cardiovascular disease, cancer, chronic respiratory disease, and diabetes, account for about 80% of all premature NCD deaths. So why are these diseases such a big problem? What contributes to their development? And those would be these risk factors. And these risk factors include the use of tobacco and tobacco-related products, the harmful use of alcohol, unhealthy diets, and those would refer to diets high in refined sugars or free sugars, and physical inactivity. So now that we've discussed about NCDs and what those are, we want to turn our attention a little bit to what are oral diseases. And oral diseases are really diseases of the mouth and the supporting tissues, and most commonly include cavities or dental caries, as the dental profession likes to refer to them as, periodontal disease or gum disease, and oral cancers. And very much like NCDs, oral diseases are also considered to be chronic diseases. And similar to NCDs, they also affect a lot of people worldwide. In fact, oral diseases affect approximately 3.5 billion people throughout the world. We also know that untreated tooth decay is the most common health condition, and more than 530 million children suffer from tooth decay of their baby teeth. We also know that periodontal disease or gum disease is also very common and affects about 10% of the global population. Oral cancer also is one of the 3 most common cancers in some parts of the world, such as Asia and the Pacific. So tooth decay, let's talk a little bit about what this means. So tooth decay occurs when plaque forms on your tooth surface and converts the sugar that is contained in the food and drinks that you consume into acids. And these acids act over time to break down your tooth structure, resulting in holes or cavities that we see here in this picture. Periodontal disease. What is periodontal disease? So we said this is an oral disease, and it affects the gum and the supporting tissues of the teeth. And it's most commonly characterized by bleeding and swollen gums. You can see that in this picture here, or gingivitis, as the dental profession likes to refer to it as. And we know that more severe forms of periodontal disease, so if these things are left untreated, it progresses, resulting in more severe forms of disease that can result in a loss of the bony support around your teeth, and you can eventually lose your teeth. So we've spoken about oral diseases, we've spoken about NCDs. We know that they are both chronic diseases. They're both very prevalent. Lots of people around the world suffer from it. But they, more than this, they share something more in common. And those would be the risk factors. So oral diseases share risk factors in common with the 4 most common NCDs, which we said before: cardiovascular disease, cancers, diabetes, and respiratory disease. And again, just to repeat myself, these risk factors include tobacco, alcohol use, as well as unhealthy diets high in free sugars. Beyond that link, oral health and NCDs are further related. So we're going to turn our attention a little bit now to diabetes specifically. And we know diabetes is linked in what we call a reciprocal way to periodontal disease, meaning it's basically a 2-way street. So that we know diabetes, if you're diabetic, you have an increased risk of developing periodontal or gum disease. And periodontal disease in an individual tends to affect their ability to control their blood sugar. So it works both ways. What data has also shown us is that in individuals who are diabetic and who suffer from periodontal disease, their risk of developing heart disease is about 3 times higher than if they didn't have periodontal disease. And we also know that there's a causal link between the high intake of sugar as well as the development of diabetes, obesity, and dental caries. So we've established that both sets of diseases, NCDs and oral diseases, are both closely linked. So we know we need to do something in order to reduce the burden of oral diseases in persons who are living with NCDs. And the advice that we would give to persons living with NCDs is pretty much the same that we would give to anybody else, with a few special considerations. So of course, we want you to keep your mouth clean at all times. And to do that, we recommend that you brush twice a day with a fluoride toothpaste. And again, we want to stress that fluoride would be the most important component of your toothpaste. So we don't want you to use a low fluoride or a no fluoride toothpaste. Your toothpaste must be fluoride containing, and it must contain at least 1,350 parts per million of fluoride. You want to brush, as we said, twice a day, but one of those times must be last thing before going to bed, and one at a time, which for most people tends to be in the morning when you wake up. We recommend that you either use a manual or power toothbrush, and that you spit out after brushing rather than rinsing with water. And this really is to avoid diluting that fluoride concentration in your toothpaste. So most of us like to brush and then rinse and rinse and rinse, but this is actually not recommended, because what you're doing is washing away all that good fluoride that's contained in the toothpaste, and it's that fluoride that's going to help prevent cavities and protect your teeth. So we recommend brushing, but brushing alone is not sufficient. So we like to tell you that you should clean in between your teeth as well. And the way that you do that is by the use of what we call incidental cleaning devices. And that helps us to clean below the gum line and between the teeth. And there are different types. There are a host of devices that you can use. But generally, the rule of thumb is if you have large spaces between your teeth, you can use interdental or single tufted brushes, they are called. So it's shaped like a baby bottle brush, the brushes that you clean your baby bottles with. And generally, if you have large spaces, this would be the type of brush that you use to clean in between your teeth. For smaller spaces, you would use your conventional dental floss. Of course, so in addition to cleaning your teeth, we also need you to make some changes with respect to your diet. And the advice that we're going to give you is going to be consistent with what your medical practitioners are telling you, particularly if you are living with a non-communicable disease or NCD. And that advice usually is centered around reducing your consumption, both the amount and the frequency of sugary foods and drinks. We also tell you to avoid these types of sugary foods and drinks. So if you do have to have a sugary food and drink, we want to make sure that it's not anywhere close to our bedtime. And this is because when you go to sleep, your salivary flow is reduced. So you tend to feel your mouth dry when you wake up in the morning. That's because saliva is not flowing as much in the night when you're sleeping. And the saliva is what protects your teeth from the acids in those sugary foods. So certainly before going to bed, you want to avoid sugary foods and drinks close to that bedtime. We also recommend for certain people who are at increased risk of developing dental decay, and you would have a conversation with your dentist and they would determine your risk level. But certainly if you are at an increased risk, you want to use a daily fluoride mouth rinse. And ideally, this should be done between your two brushing times. So lots of people use a mouth rinse, but they tend to use it incorrectly. So they would brush and then rinse immediately after with a mouth rinse. This is not the best time. And the evidence tells us that the ideal time would be between your two brushing times, which we said before was last thing at bed, and one other time, which is usually in the morning. So somewhere in the middle of the day, you want to use this fluoride mouth rinse, which bumps up the fluoride concentration in your mouth. And as we said before, fluoride is what helps to protect your teeth against those acids. So in addition to that mouth rinse, it's very, very important for you to see your dentist at least twice a year. When you visit your dentist, then this twice a year may actually get bumped up to 3 to 4 times, as I said, depending on your risk level. So when you see your dentist, you're going to have a discussion about what your caries risk is or your risk of developing oral diseases. And based on that, they're going to tell you, okay, we don't need to see you very often. We can do it twice a year, or we need to see you 3 to 4 times a year. Regardless of the amount of times they need to see you when you visit them, you should speak to them about fluoride varnish application, because again, fluoride is that very, very important ingredient in protecting our teeth against cavities. And of course, at those visits, your dentists are going to look for other signs of disease, gum disease, etc., and take the appropriate measures in order to reduce the disease and your risk of developing further disease. Certainly, if you're somebody living with an NCD, and even if you're healthy without an NCD, we always advise that if you're using tobacco or tobacco-related products, that you stop. And you should definitely have a conversation with your dentist about them offering you smoking cessation advice. So now we're turning to what are special considerations for people living with NCDs. So everything I told you before will be standard things we would tell everyone about taking care of their oral health. But persons living with NCDs need to take a few extra precautions and a few extra measures. And of course, if you're living with an NCD, particularly diabetes, you want to try to maintain good diabetic control, because of course, as we said before, you are at greater risk of developing severe periodontal disease. In addition, if your diabetic control is not good, then you're less likely to benefit from periodontal treatment if you develop periodontal disease. So no matter what the dentist is doing in each year in terms of treatment, if your blood sugar is not under control, then that periodontal treatment is not likely to produce very good results. We also know that if you're diabetic and you see your dentist regularly, and we do the appropriate periodontal treatment and we keep your gums healthy, then it can improve diabetes control among people living with diabetes. So again, very, very important if you're a diabetic to see your dentist quite often or regularly to maintain the health of your gums, which in turn will help with your diabetic control and vice versa. We also like to talk to you about medication. So people living with NCDs tend to often be taking long-term medication. Some of those medications may be in a liquid form and may be high in sugar. And if they are, then they carry the risk of increasing your likelihood of developing cavities. Some of you may also be taking medications which produce dry mouth. And if those medications produce dry mouth, then they certainly can increase your risk of, again, developing cavities, because we said saliva helps to protect your teeth. And they also increase your risk of developing gum disease. So if you're taking any type of long-term medication containing sugar or which produces a side effect of dry mouth, you want to have a conversation with your dentist, who will then liaise with your medical practitioner about what can be done, whether the medication can be changed, etc. Also, a lot of times patients who are receiving treatment for cardiovascular disease are sometimes treated with calcium channel blockers. And this type of drug, we are concerned about it because it tends to cause gingival enlargement. So your dentist, of course, will have a conversation with you. If you are taking these types of medications and they are seeing evidence of gingival enlargement, then again, they're going to be liaising with your medical practitioner about what can be done, whether that medication can be switched to one that is a bit safer and better for your gum health. So in summary, we know that both oral diseases and NCDs affect millions of people globally. We know that both groups of diseases can be prevented by modifying the risk factors that are common to both of them. And by modifying risk factors, we'll be benefiting both groups of diseases, because you're going to be preventing, once you modify risk factors for one group, you're modifying risk factors in the other group and bringing about a benefit in preventing both groups of diseases. And we know that oral health is closely related to the control and outcomes of certain chronic diseases, in particular diabetes. So that's it for today. Thank you very much.
Thank you very much, Dr. Amrup, and thanks, Dr. Amrup, as well, who is attending to a number of questions in the chat, and I think she has given a very important take-home message that dental health and the health that is derived from CNCDs, they go hand in hand, and you need to manage both, and hence it's important to see your dentist accordingly. I will now pass over to well-known who recommended us, Dr. Joel David Tilaksing, who is going to speak to us on the issues surrounding managing CNCDs within the pandemic. How do you manage your chronic disease within the pandemic? So with not much further ado, I pass over to very prominent, well-qualified, and well-known he's an associate lecturer at the University of the West Indies, Dr. David Joel Tilaksing. Take it away, Doc.
Hello, my name is Dr. Joel David Tilaksing, and I'm a consultant in internal medicine, endocrinology, and diabetes. I want to congratulate the University of the West Indies for having the foresight to organize a virtual health fair during the COVID-19 pandemic. And I have been tasked with discussing a separate global epidemic of chronic disease. And we know that link with COVID-19 has accounted for a steep spike in mortality in not just Trinidad and Tobago, but around the globe. And it is driven by obesity, increasing body weight, that fat around the tummy. It's not just a storage organ, but angry, exploding toxic fat, which secretes a host of inflammatory substances. So we could talk about SARS-CoV-2, we could talk about bird flu or global warming, but obesity remains the greatest hidden pandemic of the 21st century. And the complications are myriad, ranging from diabetes, high blood pressure, high cholesterol, strokes, gallstones, fatty liver disease, polycystic ovary syndrome, arthritis, obstructive sleep apnea, and even cancers of the lining of the womb, colon, breast, and prostate. So these are complications of increasing body weight. So it's analogous to thinking about obesity as a driver of a car. You look in the rearview mirror and all these complications are huddled in the back seat. When we're thinking about the scourge of diabetes with 537 million people globally, and it's the leading cause of blindness, end-stage kidney disease, nerve damage, non-traumatic loss of limbs, you're 2 to 3 times more likely to have a heart attack and stroke if you're a person with diabetes, it is because it is an inflammatory condition and it lowers that person's immunity, the ability to fight off infection. And similar problems occur with chronic medical diseases like high blood pressure, heart disease, lung issues, and kidney failure. And apart from the fact that there is a reduction in immunity, there is a host of inflammatory substances that create a milieu, an environment that predisposes patients infected with COVID-19 to the so-called cytokine storm. It's a cascade or sequence of events that unfortunately would result in lung failure, multi-organ dysfunction, and the need for ventilation, and unfortunately, death. What we've also found is that persons with diabetes, particularly if they have uncontrolled sugars before infection with COVID-19, would be prescribed steroids if they require oxygen or admitted to hospital, particularly dexamethasone. Now, dexamethasone reduces the chance for mortality in patients infected with COVID-19. But if added on the background of poorly controlled diabetes, there is the potential for exacerbations of infections. And we saw that with the surge of the Delta variant in India last year, in which patients got a type of black fungus known as mucormycosis with damage to the eyes, face, and sinuses. And the problem of increasing body weight, this exploding epidemic of obesity, also affects children and even pets. So similar diets that we have been indulging in, high in saturated fat, sugar, and salt, are passed on to children and to animals. And the complications that used to be noted in older persons are now being seen in primary school and secondary school aged children. And that, of course, has been exacerbated during the COVID-19 pandemic by a faltering virtual learning environment as a result of shuttered schools. They have been more sedentary, which increased screen time, and have been exposed to calorie-dense, high-fat, high-salt, and high-sugar foods. So as a result of crime-ridden areas throughout Trinidad and Tobago, and indeed the world, there are fewer green spaces and fewer opportunities to exercise. So it's not just a matter of having more calories. It's not just a matter of burning fewer or expending fewer. There are social, psychological, and biological reasons associated with obesity in children. But you'd want to view childhood obesity as a car crash in slow motion, because those persons are at an increased risk for type 2 diabetes and are more likely to get the deleterious complications that we mentioned, to eye damage, kidney disease, nerve damage, amputations, cardiovascular problems at an earlier age than their ancestors. National Geographic, way back in 2004, asked, why are we so fat? And the truth is that we have learned to be fat. We have substituted machines for muscles. We have started to indulge in this calorie-dense, high-fat, high-salt, high-sugary foods, and we have supersized everything. So it's a complex interplay, as we said, between genetics, environment, and social-cultural factors. And what about different types of diet? We've heard ad nauseum about diets that worked initially and then afterwards seemed to plateau. And it was almost as if you reached a wall at that point and couldn't lose any more weight. But I'd like to chat briefly about a Mediterranean style diet, which has been found to reduce the incidence of many of these chronic illnesses. A diet rich in fruits, vegetables, nuts, peas and beans, low fat, low salt. So if you drink alcohol, a moderate amount of red wine, and of course, not smoking. So start reading labels and you're reducing sodium, saturated fat and sugars in your family's diet. And the Mediterranean diet has been found to also reduce the incidence of diabetes, of type 2 diabetes. Vegetarians are also found to be at a reduced risk for many of these chronic illnesses. The metabolic syndrome, which is driven by central obesity, that increases the risk for all the complications we've been chatting about. The metabolic syndrome was also reduced in patients who adhered to a Mediterranean style diet. Persons have found that intermittent fasting might be useful. Have a chat with your doctor about modifications that would be valuable to you and your family. Vinegar may aid in fat loss. Daily weights, not skipping breakfast. Those might be all useful tools in the armamentarium to battle the bulge when we're talking about the obesity pandemic. There are so many different ways of dealing with this. It's not just individual responsibility, but at the familial, the society, and indeed a government must all get involved to deal with the burgeoning pandemics of chronic disease driven by obesity. So whether or not you want to reduce ads, you want to cut screen time, you want to send children back to school, you want to increase physical activity, it's all a matter perhaps of dealing with this with a knife and fork and a good pair of running shoes. And virtual encounters as a result of the COVID-19 pandemic have unfortunately been imperfect. And telemedicine is one of the paradigm shifts during this unprecedented time. And many patients, unfortunately, again, didn't see doctors. They were not sent for timely blood investigations or never got any feedback about them. Medications perhaps were not refilled. And during the lockdowns, physical activity was actually banned, which, as we know now, is totally counterproductive, not just for chronic disease, but also in the management of COVID-19. Because in the great outdoors, the chance for getting infected with SARS-CoV-2 is virtually nil. So Virtual learning and virtual encounters with physicians were imperfect, and we just weren't ready for some of these changes during the COVID-19 pandemic. Many patients were not even sent for screening of different cancers. The month of January is cervical cancer awareness, and patients missed pap smears. What about those who missed mammograms or ultrasounds of the breasts? Men were not sent for prostate checks and even colonoscopies after the age of 50. So another spectrum of chronic disease patients, another group was underserved during COVID-19. And just some general principles, because I know that we'll be chatting a little bit about the nuances in the management of COVID-19. Some of the principles include ensuring that you know emergency numbers, you keep hydrated, and treat any symptoms such as fever with paracetamol, fluids, rest, and ensuring that if you were infected, particularly with these highly transmissible variants such as Delta or Omicron, that you manage your symptoms at home and liaise with your physicians remotely if needed. And if there are any red flags like chest pain, shortness of breath, blueness to the lips and fingers, if you have changes to your blood pressure, blood sugar, your levels of oxygen, ensure that you seek a higher level of care. Do not stay at home with your symptoms. Some of the home remedies which have been touted include steam, perhaps some vitamins like C, D, and zinc, and you may want to add those to your therapeutic arsenal in the management of COVID-19, and ensuring that chronic diseases are immaculately controlled during that time. And avoidance remains the watchword when it comes to SARS-CoV-2 management, but perhaps it will be difficult with these variants, even for the fully vaccinated patients. Social distancing, high quality masking like N95s, don't use those cheap cloth masks, they don't prevent transmission. Improved ventilation, that remains an under-recognized tool from the 19th century to reduce transmission of respiratory viruses. And of course, vaccination. Vaccination is our best exit strategy to the pandemic, and there is a definite reduction in the risk of severe infection, ventilation, and death in persons who are fully vaccinated. The variants admittedly are more likely to cause breakthrough infections, but you are less likely to have severe manifestations if you are vaccinated. So afford yourself an opportunity of a freely available COVID-19 jab while avoiding the 3 C's. Closed, crowded, close contact settings. Closed, crowded, and close contact settings are more likely to be ideal petri dishes for infection with SARS-CoV-2. It would be remiss of me to have a discussion on chronic disease and not mention the hidden or silent pandemics of depression and anxiety or post-traumatic stress disorder. 10 to 30% of patients who have ostensibly recovered from the ravages of COVID-19 are more likely to have problems like reduced sleep, a reduced appetite, diminished memory or concentration, low self-esteem, and even suicidal thoughts. There are feelings of hopelessness, helplessness, and worthlessness, and they may have a long COVID type of syndrome. It's commendable that the RHAs in Trinidad and Tobago have actually identified patients with long COVID and started clinics to follow up these so-called recovered patients. And we're unsure as to the modes of management and even the duration of their symptoms. Many persons may be gaslit by their physicians as having no problems, but they're actually struggling with long COVID. If you're having symptoms associated with depression, anxiety, or post-traumatic stress, help is available to you and your family. Reach out to a friend, a relative, or your physician. Listen to music. Start exercising, the great outdoors, not just for the management of your numbers like your sugar or your blood pressure, but also to soothe the mind. Meditation, yoga or prayer, and avoidance of too much information, or should I say misinformation, as part of the infodemic since the start of the COVID-19 scourge. Because there is so much false information that would be disseminated that would be confusing and perhaps would worsen your fare. Take a break from social media like WhatsApp messages or Facebook from time to time. It might do you a world of good. These are common problems and highly treatable. So the focus with respect to chronic disease should be on good habits. A diet rich in fruits, vegetables, nuts, peas and beans, low fat and low salt, and you're reading labels, and avoidance of bad ones. And when we're thinking about avoidance of a sedentary lifestyle, you want to walk, run, jog, bike, or even Zumba, 30 to 60 minutes for most days in the week. As we mentioned, it's not just for your physical, but also psychological health. This week marked 100 years since a 14-year-old type 1 diabetic boy was administered the first injection of life-saving insulin. Leonard Thompson received this shot from Charles Best and Frederick Banting in Canada, and it was a groundbreaking discovery. So we celebrate 100 years since the first patient received insulin. And it's ironic that as we stand on this point, as we stand at this point, persons are still struggling to access this life-saving medication and still locked in fear and perhaps mystique in diabetes management. A simple way of remembering what we've spoken about today would be to remember your ABCs. A for your hemoglobin A1C. If you're a person with diabetes, it's a measure of blood sugar control for the preceding 3 months, and keeping your level of A1C to 6.5 or 7% would reduce the risk for eye, kidney, and nerve damage. And it's thought that if you have tight control of your diabetes in the early stages of diagnosis, the body has a metabolic memory and it creates a positive legacy. So perhaps a decade later, you're at a lower risk for heart attacks and strokes. So A for A1C, B for blood pressure control. You're trying to keep your blood pressures under 140/90 millimeters of mercury to reduce damage to the eyes, kidneys, blood vessels, and heart. And if you're a high-risk patient, your physician may say, try to keep a target of less than 130/80 millimeters of mercury. C for cholesterol, and it's all about knowing your numbers and dealing with it appropriately if needed. So total H or LDLs, the so-called good and bad types, triglycerides, all important and part of your lipid profile. D, don't smoke, reduce the incidence of diabetes. Prevention is the watchword, and you can actually reverse your diabetes. Type 2 diabetes, if associated with insulin resistance and obesity, can be reversed. And of course, D for don't smoke, and E for exercise. Physical activity cannot be underemphasized with respect to prevention, running, walking, and dancing away from chronic disease. And I just thought it would be appropriate to close our discussion with a quote from William Shakespeare and his play Julius Caesar. Men at some time are masters of their faith. The fault, dear Brutus, is not in our stars, but in ourselves, for we are underlings. So I know we don't have time for questions as part of this virtual health fair, but I would like to invite you to join me on Ask the Doctor Thursday nights at 8 p.m. on CNC3. We're not just speaking about COVID-19 and chronic disease, but any medical related issue. And we'd love to hear from you. Ask the doctor. And in closing, the watchword for our discussion is prevention, whether it's dealing with diabetes, high blood pressure, cholesterol, heart disease, strokes, or cancer. And we want to target the separate pandemic of obesity. So diet, exercise, weight loss, stopping smoking, limiting alcohol, and avoiding stress are all pillars. Those are fundamental aspects to reducing the burden of chronic disease in the midst of the COVID-19 pandemic. Look after yourself so that I won't have to. Enjoy the rest of the symposium, and God bless you all.
Thank you very much, Dr. Joel David Tilaksing. And just to let you know, I'm seeing the chat. Most of the questions are actually being answered in the chat, and they're being answered appropriately. I will ask Dr. Ocho as well over this. There are a few questions that he can check with America to really get those questions answered when it comes to diet. Now it's the fun part of our program. We have another giveaway. The first giveaway is actually sponsored by Bride and Pie. It's a hamper. And the question is very, very simple. It's taken from all three presentations. And let me give the question order so that you all will be able to answer it. And you answer in the chat. First person to get it correct, you get your hamper from Bride and Pie, and Ms. Amrika Ramdas will collect your information as well, so that we can make arrangements following all COVID protocols to ensure that you are able to collect your prize. So that first question that we have for today, it's a three-part question. Question one, what portion of the plate should your breakfast be? Part B of the question, what is the concentration, minimum concentration of fluoride that has to be in that in your toothpaste going forward? So those are the two questions. What, A and B? So I am seeing some correct answers coming through, and I saw some persons, Ms. Ramdas, go through and find who would have answered first. I saw some people have just answered half. You have to answer both questions in one. So the person would have answered A and B in one first. I am seeing quite a number. So after the end of this round, I will ask Ms. Ramdas to just go through the chat. And the answer is half a plate, and 1350 parts per million is at minimum concentration. So I hope to have a winner to announce at the end of this, during this session. I will now like to get into session 2 as we move forward. And we move into this health fair. Session 2 is one that looks at drug management and how do you deal with your pharmaceuticals during the pandemic. And in this session, we are very fortunate to have persons who have been associated with the School of Pharmacy and persons who have been associated, who continue to be associated with the School of Pharmacy to present. And I'd like to present, first of all, our lecturer, Dr. Diane Ignacio, who will look at how do you store and manage your medications. How do you store and manage your medications? And I pass over to Dr. Diane Ignacio now. Please take it from here, Doc.
Storage of medicines. How to keep your medicines safe. If you have ever taken a medicine, whether as a prescription from your doctor or a vitamin from the shelf of the pharmacy, information about storage should be on the label. Every household has some type of medication. We need to know how to store them properly so that they work as intended, and also to store them properly so that they are safe from children. Medicines should be stored in locations that are safe. Storage of medicines, general principles. It is important that medicines are properly stored so that they work well for the purpose that they were prescribed for you in the first place. Heat, air, light, and moisture can spoil your medicine. They should be properly stored so that the quality is not ruined. Storing them suitably also prevents poisoning accidents, especially poisoning of children. It is important to store medicines properly to keep your family members and the visitors safe in the home. It is critical to note
that medicines should also be stored away from persons who need help in managing their medicines. These persons usually need caretakers because they are not able to read or understand labels. The pharmacist should give you, the consumer, information about the proper storage of the medicines that they are dispensing to you. The information should also be well placed on the label of the container so that it is visible. To prevent poison accidents and even loss from spillage, containers should be closed tightly after each use and should be put away carefully in a suitable place. Protect medicines from getting damaged. Medicines come in many different forms: capsules, tablets, inhalers, liquids, injectables, eye drops, patches, creams and ointments, and others, and should serve the purpose for which each was intended. One thing that they have in common is that they don't and won't last very long in extreme temperatures. All medicines, whether they were prescribed by your doctor or recommended by your pharmacist, if not stored properly, may not do the job they were intended to do. Where and how you store your medicines can affect how it works for your medical condition. Extreme heat or cold can cause them not to work well or not work at all. For example, an inhaler for asthma or a tablet to lower your blood pressure may not work when required. Some special drugs like birth control pills, chemo pills, chemo drugs, anti-seizure medicines, and antibiotics don't work well when stored or exposed to temperatures that are outside their recommended storage temperature ranges. Heat, air, light, and moisture can ruin them. Medicines must be stored in a cool, dry area. Never store medicine in the bathroom medicine cabinet or in the sun. Heat and moisture from taking hot showers may also cause some medications to become ruined. So what are some of the good places to store them? Areas like your dresser drawer, a high shelf or closet in the bedroom may be appropriate. Some high cabinets in the kitchen may also be suitable, but not in cabinets close to the stove or the toaster or dishwasher. Of course, medicine should never be frozen. Extreme cold can also cause them to become damaged or lose their effectiveness. Do not use damaged medicines. Never use damaged medicines. Always inspect them before taking. Damaged or spoiled medication can make you sick. Remember, pills, capsules, tablets are easily damaged by heat, moisture, and even coldness. These damaged medications can irritate your stomach. For example, spoiled aspirin can break down into vinegar and acid and irritate your stomach. So how do I know medicines are damaged? You may be asking, how can I know if the medication is damaged or not good to take? Take a minute to look at your medications before you pop them into your mouth, inject them into your body, or even rub them on your skin. Sometimes there may be a change of color, texture, or even have a funny or different smell. Sometimes they may appear runny. Sometimes the tablets or the capsules may be stuck together. Sometimes they may be chipped or cracked. They may feel harder or softer than normal. These are signs of visible spoilage. Spoiled medications lose the potential to work. For example, an infection treated with an antibiotic may not get better, or the infection may last longer or take longer to be healed. Just remember, Not just because a medication looks normal, it is okay to use. It may have still been damaged by heat, moisture, or coldness. You cannot often tell if there's a problem by just looking and seeing the changes. There could still be a decrease in effectiveness or potency, even if there are no visible changes. If you have any concerns, consult with the pharmacist. So how do I get rid of old or expired medicines? Always check the expiration dates of medicines before taking them. So these include prescription or non-prescription, what we call over-the-counter medicines. Old and expired medications should not be kept. They should be discarded. Do not flush medicines down the toilet unless you know for sure they are flushable. Ask your pharmacist. They can be thrown away in the trash, but in very specific ways. Medicines can be thrown in the trash using the following steps. Remove them from the packaging. You can mix them with coffee grounds, dirt, or cat litter if available. This makes them less desirable to children and pets, or even unrecognizable for intentional persons searching through the trash. Put the mixture in a sealable container like a Ziploc bag, an empty can, or a bottle to prevent them from leaking out. Then throw the container in the garbage. You can also return any old or unused medication to the pharmacy. Remember to ask your pharmacy how to get rid of old and expired medicines. Never store medications at high temperatures. Medicines, they come in different forms and they serve many purposes, but they do not do well in extreme temperatures, hot or cold. Never leave your medication inside a hot car. They may actually become less effective. The impact of a not so effective heart medication or an inhaler for asthma may be fatal. In our hot climate, consider keeping certain medications in the refrigerator if you don't have air conditioning. Ask your pharmacist. Never store medications at high temperatures, which can cause deterioration, loss of potency, or spoilage. Some asthma medications can explode when stored at high temperatures. The medicine contained in them can also become less effective and may not work to stop an asthma attack. Ask the pharmacist about what you can and cannot store in the fridge. Now let's look at storage of insulin. There are many types of insulin, and they all require proper storage. It is important to store as directed so they remain usable. So safe and effective use of insulin requires proper storage. Not all insulins are stored the same. Find out from your pharmacist how to store yours, because improper storage could result in breakdown of the insulin, which decreases control of your blood sugar levels. All insulins are sensitive to high or low temperatures, and all must be stored in the refrigerator. Once a new vial is opened using a needle, you need to note the date opened on the package and store it in the fridge or at room temperature. After 28 days, you throw it away after opening it. Do not inject cold insulin. It may be painful. Do not use insulin that has been frozen. Sunlight can also degrade insulin. So keep it cool, right? Insulin should be stored in a proper working refrigerator. You should store them around 36 to 46 degrees Fahrenheit. That's about 2 to 8 degrees centigrade. Do not allow insulin to freeze. The back of the fridge is usually colder and may cause this to happen. Do not use insulin that has been frozen. Always know the expiration date. Follow the instructions on the package and keep unopened insulin refrigerated until the date on the package. Discard open insulin within 28 days. There are some insulin products contained in vials or cartridges supplied by the manufacturers that are open or unopened. They may be left unrefrigerated at the correct temperature for up to 28 days. So these can be kept open or unopened for up to 28 days. Avoid extreme temperatures. Insulin loses some effectiveness when exposed to extreme temperatures. This can result in loss of sugar levels over time. Do not store your insulin in the direct heat or direct sunlight. So, inspect insulin before each use. You should look for changes in color or for cloudiness. Keep in mind that clear insulin should always look clear, never cloudy. Do not use normally clear insulin if it becomes cloudy or if it changes or turns a different color. If you see crystals or clumping, do not use. Store medicines safely to protect your children. It is of paramount importance that medicines are kept stored away from children at all times. If ingested unintentionally, they may cause harm to the child. Store all medications in high places, preferably in locked cupboards where young children cannot reach them. To prevent poisonings from intended or unintended use, close the containers tightly after each use and keep the medication there until it's time to take them. Never leave the next dose out as a reminder to give or take them. Never leave a child's medicine at the sick child's bedside, even if a dose has to be given in a couple of hours. Some medications can look like candy to children. Use a safety cap if possible. So store them out of reach and out of sight. Place them in high locked cupboards. Unpack all medicines from shopping bags, and that includes vitamins and supplements. Never leave them on countertops or place them on the floor, and do not place them in cupboards under the sink. You should store any purses or diaper bags, etc., out of reach and out of sight. Don't store them on nightstands or dressers. Check floors under the bed for pills that may have fallen. And also remind grandparents, friends, guests to keep their purses and medications out of sight. Do not take medicine in front of young children. They may copy you and try to take medicine just like you did. If you suspect a child has ingested medicine, check their mouth, collect any medicines and medicine containers that the child might have gotten into, and call the National Toll-Free Poison Center, 1-800-2-PIC, to get advice from an expert. So in conclusion, storing medicines properly takes a little effort, but it's a good practice to help keep yourself and others safe. Having medications at home that are not properly stored increases the risk of accidental poisonings. Medications that are not properly stored may not work as intended. Remember to call the toll-free National Poison Center, 1-800-2-PIC, to get advice from an expert. Thank you.
Sorry about that. Zoom, we learn all of these new things. And I'd like to thank Dr. Extavo and Dr. Ignacio for attending to some of the questions in the chat. Our very next speaker is someone who worked closely, worked very hard and diligently in the School of Pharmacy. Unfortunately left us for better things, went on to CAFA, but continues to give great service to this faculty. Dr. Rian Extavo, who has been qualified in the area of pharmacovigilance as well as pharmacy administration, PhD. Is actually going to give views around vaccines and the issues around persons having adverse side effects. So if you do have an adverse side effect, what do you do? And this is where Dr. Extavo is going to speak to you all today about reporting vaccines adverse reaction. And I must thank Dr. Extavo and CAFA, her boss, Dr. Joyce and Bernard, for giving her the opportunity to present today. So I'm passing over now to Dr. Rian Extavo. What do we do and how do we report if we have a vaccine adverse event? Thank you.
Good afternoon. I'm Dr. Rian Marie Extavo, and I'm the Program Manager at the Caribbean Regulatory System under CAFA, the Caribbean Public Health Agency. And today we are pleased to join with the University of the West Indies to present briefly a little lecture for you on vaccine adverse event reporting. As we know, COVID-19 vaccines have been in use globally for over a year. However, we're still learning some new aspects, not just about the virus, but also about the vaccines. So it's important for national health authorities, international and regional agencies, health workers, and patients to get an idea of the safety profile of these vaccines so that they could be assured or understand if anything has to be changed as to how they are used or when they are used and which ones are used in different populations. So this is part of a bigger concept called pharmacovigilance, which is generally monitoring safety and quality of medicines, vaccines, and other health technologies. So it's not a new concept. It's been something being practiced in different countries around the world. So let's keep in mind that we're now applying something that has been learned about, practiced, and we've had different studies emerging about it. So I will share my screen so you can follow some of the points I'll be making. So moving forward, at the Caribbean Regulatory System, we undertake monitoring by helping countries to collect reports of adverse events, both for medicines as well as vaccines. One of the first things people need to understand is what they can expect when they receive the vaccine. So the benefits of vaccines have been pretty much well established. And the main goals for the vaccines are to prevent severe illness, to reduce or prevent hospitalization, and to prevent deaths as far as possible. However, just as we have benefits, we are aware that there would be side effects or responses your body would have to receiving a vaccine. And these are commonly expected because your body will respond while it's mounting its defense. Some of these common side effects are soreness or redness at the injection site, fever or chills, tiredness, persons may feel unwell, there may be headaches, some persons may have a headache, or there may be muscle or joint aches. Keep in mind that not everyone will experience side effects, and that these usually last a few days. When we refer to adverse effects, however, or adverse events, what we want you to pay attention to is where you may have had an unexpected side effect that lasted longer than you expected, or was more severe than you expected to be, or you have an experience that was not listed at all among these common side effects. If that happens, make sure that you seek medical attention. You may go to the health facility where you got the vaccines reported, or you may go to your physician, your own personal physician, or you may go to a public health facility for medical attention. Why is it important for us to make note of adverse events following immunization? Another term you'll hear is ESAVI, or events supposedly attributable to vaccines. And these events, when they're pooled, when they're validated, when we clean up the data and when we do our analyses, the information that emerges helps us to better understand how the vaccines affect local populations. It helps regulators and agencies to identify new safety issues that were not seen in the trials that went before or while in use in different populations. It helps to review the benefit-risk balance of the vaccine, because that's what we're ultimately always assessing, how the benefits and the risk balance out, and to develop actions where necessary to protect the public from any undue harm. What happens when that adverse event report is made? But first of all, when you go to seek care and the health professional will check your symptoms, they will also check to see if there are any other related conditions or what happened around the event, maybe what led up to it, what foods or medicines you're using at the same time. Also, they may ask questions about when the vaccine is given. And that report is submitted to the Ministry of Health. The Ministry of Health then seeks to verify the reports, and depending on the severity or the seriousness of that report, they would launch an investigation with a specially trained team. Now at CARFA, we are aware that some of our member states may have populations of persons living in far areas that may not be able to physically return to health facilities. So if you go to our website, we do have a section for online reporting, and those reports are sent to the Ministry of Health's focal points, and we retain that confidentiality as per CARFA's policy. The Ministry of Health would also investigate to check to see if there are other similar reports coming from that facility or clusters. They would also want to see if there are any issues that occurred during storage, during transportation, or during administration, so that they could really help formulate a solution for the use and to make sure it's used safely. The third step is where there's a safety committee appointed by the Ministry of Health. That safety committee oversees analyses of the reports that have been verified and investigated. They would also do an assessment that informs or helps us evaluate the benefit-risk balance with using that vaccine versus not using it. And of course, make recommendations for actions that may be taken. Regulatory actions may include restricting who receives the vaccine. They may give it an age restriction. They may decide certain persons with a given comorbidity or given conditions cannot take the vaccine or should not take it, or use an alternate vaccine that does not trigger that particular event. Or they may decide that there needs to be some additional systematic changes or training. And in some cases, very rarely, the ministry may decide they would have to suspend use of the vaccine according to internal protocols. This is an overview of that whole vaccine safety evaluation step I was referring to. So we do have voluntary reports, those reports of adverse events following immunization, where you see AAFIs, also called ESAVIs. Those can come from the public or healthcare professionals, but manufacturers sometimes also receive these reports. And those reports are fed into the national authorities system. They're validated. For those that have been found not to be attributed to the vaccine, those are completely ruled out, because you don't want to spend a lot of time on reports that are not, clearly not related, or there's absolutely no link possible there. When they investigate reports and there is a potential link, that informs the risk-benefit balance. And if there's an unpleasant or unfavorable imbalance where risks outweigh the benefits, then the medicine or the vaccine may be suspended. Additional information may be used from published studies, from global databases, and from safety studies that manufacturers are undertaking. A few things to keep in mind. Patients may not want their full name listed on that report just yet. So the reporter can use their initials, send it to the ministry, but the ministry needs to be able to contact that reporter for full details and to verify that person's existence, the conditions, and what happened around that event. It's important, or at least helpful, to keep a diary of the effect or the event experience, what led up to it, what happened before, when did it start, when did the symptoms stop, if you were taking any other medications, if you applied any other remedies, and any other conditions you may be treating yourself or a physician may be treating you for. It's also very rare to find a vaccine having caused a serious adverse event. However, we don't take it for granted and we still need to monitor. So reports are important for us. Some reports may include coincidental events. And that's why that step for investigation and verification is so important before they do the analysis. And because we have so many coincidental events that could occur, it means that seeing on a website, oh, we've gotten 10,000 reports on a specific vaccine, doesn't automatically mean it's unsafe. We can't assume that because there's the other steps for investigation, analysis, causality assessment. Those are still important and they need to be done before action is taken, because you could discard something that's perfectly still in use. If you're worried about the reporter getting into trouble, they won't. The principle of safety and quality monitoring of vaccines, medicines, and other health technologies is well established. And ministries of health are aware that they need to work with health professionals and with the public to understand what the public is experiencing. So that's an important principle of pharmacovigilance around the world, not just for Trinidad and Tobago, or not just for CARPHA member states or the Caribbean. So in all, the goal of reporting is to inform this benefit-risk balance for vaccines, in this case COVID-19 vaccines, but also medicines and other health technologies. As well as the benefits, we need to make sure that the benefits continue to outweigh the risks while we're using a product. Once that balance changes, and if the risks ever outweigh the benefits, then we need to take strict action to protect the public from undue harm. So voluntary reporting of adverse events following immunization or SRVs, this helps the national authorities to see the safety, or to understand the safety profile and to see what's common among the population. Because there are some conditions we consider baseline. We expect a certain number of persons to live with or to have certain conditions, for instance, chronic diseases, but we need to be able to determine which ones are routine for the expected conditions and which ones are triggered by a medicine or vaccine, or maybe incorrect use. Maybe we need to retrain people. Maybe we need to have the manufacturer change the way it's packaged so we make less errors. And all of that contributes to pharmacovigilance. So each person has a part to play. Let's do our part to monitor vaccine safety. Thank you and have a great day.
Thank you very much, Dr. Exavo, for a very informative session. And, you know, Dr. Exavo has given some options to us. Where do you respond and where do you send your queries? And it's very informative, and she has also been answering some of the questions in the chat. One quick question in chat, I'll just like to update to ensure that persons know this. I saw it there and I think it's important. Persons are asking on expiries. The reason, yes, the drug may work, but what tends to happen after the expiry date, the drug degrades and there can be potential toxic components after that. And hence, you're not too worried about the active ingredient, but you're actually worried about those potential toxic excipients. And as we talk about toxicology, no better person to speak about toxicology than our PhD in toxicology, our person who is the head of the Trinidad and Tobago Poison Information Center, the man who knows everything about toxicology, and I have an honor that he taught me actually in school, Dr. Verrill Simmons, who is going to deal with a very important topic, that of how do you manage your household during the pandemic? Because believe it or not, your household has a number of toxic items, and how do you manage that during a pandemic? Because now the household is the domain, it's the school, it is the place that you sleep, so it is also the place of work at the end of the day. So the household is now everything during this pandemic. So Dr. Simmons, I pass over to you now to deal with that. Thank you.
Good day. I'm speaking to you on the topic of managing chemicals in the home during a pandemic. I'm proposing to start with a broad overview of what the current picture looks like, and then move on to speak to some specific chemicals of concern and tie it up with a summary of the key precautionary steps. Do you know that the majority of poisonings occur in the home? Most poisonings occur when parents or caregivers are home but not paying attention. The most dangerous potential poisons include medicines, cleaning products, pesticides, furniture polish, gasoline, and kerosene, or as we call it in some quarters, pitch oil. Usually, we caution parents and caregivers to be especially vigilant when there's a change in routine. For instance, during holidays, visits to and from grandparents, and other special events. At these times, there is a greater risk of poisoning if the usual safeguards are defeated or not in place. With families spending more time at home because of the COVID-19 pandemic and distractions brought on by the pandemic, such as trying to manage childcare while working from home, the chances of young children getting into contact with possible poisons may increase. Poisonings are more likely, and therefore prevention steps are even more important. As people focus on cleaning and disinfecting their homes during the pandemic, poison centers globally are reporting an increase in poisonings of both children and adults at home, especially from cleaning products. As COVID-19 spread worldwide, from very early in 2020, our health ministry joined with other regional and international partners in communicating recommendations for proper cleaning and disinfecting of high-touch areas using household disinfectants and cleaning products. Cleaning and disinfecting continue to be important COVID prevention strategies. Bleach, hand sanitizer, and other cleaners and disinfectants do work to kill viruses and bacteria, but some of these products can be poisonous when handled improperly or when adults and children accidentally swallow or touch them. The slide lists some of the commonly used cleaning products. I wish to focus on the last bullet point. Detergents in single-use laundry packets, very concentrated and can be toxic. Even a small amount of the detergent can cause serious breathing or stomach problems or eye irritation. Never let your children handle or play with the packets. The packets dissolve quickly when in contact with water, wet hands, or saliva. Biting a packet can cause it to burst, shooting detergent into the child's mouth, throat, or eyes. Remember to reseal the container and store it, preferably in a locked cabinet, after each use. Make sure the container is out of sight and reach of children. Some tips on cleaning safety. Use one cleaning product at a time. Do not mix products unless the label says so. Open windows and doors to ventilate the area if recommended by the label. Do not use bleach, disinfectant wipes, or cleaning sprays on skin. They are meant to clean surfaces in your home and may cause skin irritation. Do not swallow cleaners or disinfectants. These are not safe to put in your body and will not treat or prevent COVID-19. And last but not least, in terms of cleaning safety, turn spray bottle nozzles to the off position right after using them. Remember that washing your hands frequently is the most important cleaning you can do. Use hand washing basics and practice them often as we fight the spread of coronavirus and other illnesses. Washing your hands with soap and water for at least 20 seconds is the preferred and recommended way of cleaning. Using hand sanitizer containing at least 60% alcohol can be an effective way to clean your hands when soap and water are not available. Store-bought hand sanitizer does not necessarily mean it is safe for use or effective. Some formulations may contain several potentially harmful ingredients. It is important to check the quality of the hand sanitizer you use. Consumers are especially warned to avoid hand sanitizer brands that are contaminated with methanol. This methanol is a dangerous chemical that can be toxic when absorbed through the skin and can be life-threatening if swallowed. Methanol exposure can result in serious illness or death. So, some general safety tips to follow while using hand sanitizer. Do not swallow any hand sanitizer and never use hand sanitizer on the hands before lighting gas stoves, lamps, or candles. Only use hand sanitizer for its intended purpose of cleaning hands and to properly use the hand sanitizer, apply a small amount to the hands and rub the hands together until dry. Always supervise children when using hand sanitizer. And never lose sight of the fact that you need to remind your children to keep their hands out of their mouths after the hand gel is applied. There's currently no evidence that the virus is transmitted in food. So when washing produce, you should use water and not any of the cleaning chemicals. Something that we often overlook in the food and drink area is alcohol. Alcohol can be very poisonous to a young child, and you should remember to empty any unfinished drinks right away and not leave it for the enterprising, opportunistic child to access. Small objects can be choking hazards or may be harmful if swallowed. So floors should be checked regularly for small objects. This is particularly important if someone in the household has a hobby that involves small items, or if they are older children who have small items. And we're speaking about things like beads, pins, buttons, refrigerator magnets, screws. I want to say a special word about button batteries. These can cause severe injury or death if ingested. So you should make sure that battery covers are secure on things like remote controls, key fobs, musical books, and greeting cards. Devices that contain button batteries should be stored out of reach and sight of children. The elderly or senior citizens are increasingly isolated due to the pandemic. It is particularly important to secure and clearly label any medicines and poisonous substances in their environment. Elderly persons are particularly at risk of mistaking medications and accidentally ingesting household products. So, to summarize the do's and don'ts of managing chemicals in the home, always keep household products in their original labeled containers and make sure they are properly closed. Store all household cleaning products safely to prevent poisoning. Remember, small children are often eye level with items under the kitchen and bathroom sinks. So store medicine, household cleaning products, and personal products up and away, out of children's reach and sight, and preferably locked up. The safest place to store poisonous products is somewhere a child can't see or reach. It is also best to use traditional liquid or powder laundry detergents instead of the detergent packets until all children who live in or regularly visit your home are at least 6 years old. Wash your hands after handling chemical and cleaning supplies, and follow safety precautions when handling any cleaning or disinfecting product. Read and follow product labels. Check for ingredients that can be dangerous to children, and make sure you store products according to the label. Children can get into things very quickly, so remember not to leave cleaning products or personal care products unattended while you are using them. Remember to consider products or things in the child's surroundings that might be harmful to them. Know the names of all plants in your home and garden. If you have young children or pets, consider removing those that are poisonous. There are some no-nos. So never place poisonous products in food or beverage containers. Never mix chemicals or cleaning products together. This could create toxic fumes. And never assume that because a cleaning product contains natural chemicals that they are harmless. Some of these cleaning products may contain essential oils that can be dangerous to adults, children, and pets. If someone is unconscious, not breathing, or having convulsions or seizures due to poison contact or ingestion, call 811 or your family physician immediately. This is a potentially life-threatening exposure. To get help from the Poison Information Center, you can call 800-2-PIC, which is 800-2742. The service is free, expert, and confidential. And remember, almost anything can be a poison if used in the wrong way, in the wrong amount, or by the wrong person. Finally, a reminder, I didn't touch much on medicines because it's likely to be dealt with elsewhere. But if you look at this image, if the containers were removed, would you know which was the sweet and which was the medicine? Children don't know either. Thank you very much.
Thank you very much, Dr. Simmons, for a fantastic presentation there. Now, just to let you know, Dr. Simmons, I don't know if you can do a few questions in the chat. One is if bleach can be used to wash vegetables, how safe that is, and you could kindly answer that in the chat. And another one wants to know what are some non-toxic ways of getting rid of household lizards? If you can deal with that, Doc, as well. Thank you. At this point, I want to announce the winner of the Bride and Pie hamper. It was Miss Dina Sanka, who answered first. And we will like to thank Miss Sanka for that. We'll also, so congrats, Ms. Sanka, on behalf of us, and Ms. Ramdas will be contacting you to get your information, please. And also, the question for this session, we'll go on a break soon, so you will get 5 minutes to just detox from this and come back. But first, you must ask a question. And this section, we are very happy to have a hamper sponsored by PNS Pharmaceuticals. And that question is, what is the problem with injecting insulin that is cold? Dr. Ignacio alluded to a problem. I'm just asking one, no part A, B. So it's whoever answers first. And I see it's going very, very quickly. So she said a specific problem. And after the break, we will announce the winner. Coming right after the break, we have Professor Vijay Narayan Singh, who is going to give a very beautiful lecture on diabetic feet in Trinidad and Tobago. Hi guys, and as promised at 11:15 we are back. First of all, I'd like to announce the winner of that last hamper. It is Miss Ariane Bain. It's painful. That's what Dr. Ignacio said in her lecture. We got some fantastic answers and some answers that will also be right, but the one that she did say in her lecture is that it's very painful. And we can definitely thank Miss Ariane Bain. So congratulations, Miss Bain. Ms. Ramdas will be reaching out to you to get that information so we can get that over to you as soon as possible. This section coming up here, we have very close attention again, a fantastic hamper being done by Massey Distribution that will come your way. And we are now going to engage Professor Emeritus, well-known, highly published with over 324 publications, and a person who is highly cited, Professor Vijay Narayan Singh, who has done a lot of work on the diabetic foot. And this is a body of work, almost a life of work, that you all are going to see presented here today. And I myself am really awaiting to see this presentation. Professor Narayan Singh is going to join with us, and I will pass over now to Prof. Narayan Singh.
Diabetic foot is in fact a national disaster. We see an increasing incidence of diabetes because of aging, obesity, increasing in the young, and Indians more than Africans. The diabetic foot is the most expensive surgical disease because it involves many operations, long hospital stay, lots of antibiotics, and it's also costly to the family because of loss of income, loss of independence of the patient, family issues of managing such patients, and so on. We worked out that nationally it costs almost $600 million TT per year to manage diabetic foot in our public institutions. In addition, when patients seek home remedies and then come to hospital with complicated disease, it costs about $70,000 more for each patient, with an increased number of operations and increased risk of limb loss. The diabetic foot, the commonest cause of infections is trauma, often puncture wounds. It's about 80% in Barbados and about 60% in Trinidad. The ischemic foot accounts for about 20% of our limbs lost, and it's because of occluded blood vessels, which is common in diabetes. Then we have the osteoarthropathy, which is bony destruction, and neuropathy, loss of sensation. And when we see these punched out lesions, often it's because of loss of sensation and osteoarthropathy, and we must x-ray these feet. Skip that. And here you see the bony destruction from osteoarthropathy. Again, you can see osteoarthropathy in a case like this where you get redness, swelling, warmth, but you notice the bony deformity here and the flattening of the pedal arch. And here on a lateral X-ray, you can see a normal pedal arch here, and you can see flattening with bony protrusion in midfoot here due to collapse of the midfoot. And these can lead to ulcerations in the middle of the foot. Here, when you see redness and warmth and you see any structural abnormality, we must do x-rays. And here you see bony destruction. This is an early case where proper footwear can alter the mechanics of the arch. Here you have infections that can occur without the patient recognizing it. Here, this patient just noticed swelling for 2 months, and it's only when there was oozing, foul smelling in the last 6 weeks that he tried home remedies, and then with failed home remedies came to hospital with this oozing, swollen big toe. And here on x-ray, severe osteomyelitis with bony destruction. This toe has to be removed to save the foot. And here, removal of the toe saves the foot. Sometimes you see a lesion that looks like it's just the toe involved, and here you see a gangrenous toe. But when you look at this, this is spreads under the skin. The skin looks normal, but there's widespread gangrene ascending right up to above the ankle with a lot of necrotic and gangrenous tissue, which we have to excise and drain. A normal looking skin, but gangrenous tissue below the skin. So the skin appearance is very deceptive. Here again, you have a case where you have normal looking skin, septic tissue here, but when you open that normal looking skin, you see gangrenous tissue there. So here is spreading across the base of the foot, and we have to excise the gangrenous tissue to save this foot. This non-healing ulcer at the tip of the big toe, and here you see a hammer toe deformity. So the tip of the toe is where the pressure is maximal, and you get ulceration. When we do a tenotomy, it cures that ulcer in a very short time. Similar story here. Ulcer, debridement of the ulcer, tenotomy, and in 20 days, it's completely healed. It is uncommon to get such superficial infections here where it's very obvious that all this is red and infected. And this is just a subcutaneous infection. There's a cavity below the skin. There's a lot of pus. You can clean this out and clean, wash it out, and so on. And you can save this foot. But when it's deep to the fascia, it's not so obvious. This is an example of where it's deep to the fascia. Here there's gangrene here, and from this point on looks normal. Here there's gangrene, same patient, and from this point upward looks normal. We went to do a below knee amputation here, and when we go below the knee, perfectly normal skin and gangrene in the muscle layer below. That's why I call this rotten Zabuka syndrome. It looks good on the outside, but it's quite rotten on the inside, and the skin is quite deceptive. So thus we see it spreads across the base of the foot, and it also spreads upwards in the foot. Now, when we see puncture wounds, here's a patient who had a puncture wound that's not healing, and 10 days after that, he notices swelling of the dorsum. And when he comes to hospital, this is what it looks like. Once we see from the sole of the foot to the dorsum, we must do an x-ray. An x-ray here shows that he has a foreign body, a piece of metal there. So we have to go in and do a debridement here, and the gangrene is extending all the way up to well above the ankle, and he loses that toe. Here's another case. Patient has a puncture wound here, and for 4 weeks, it's not healing, and he sees swelling and develops another lesion here. So there's cavity from here to here under the skin. And then we see on the dorsum, he has changes as well. An x-ray again must be done. And here you see there's bony destruction. So he has infected bone there as well. And here is the cavity. We have to open that cavity, clean it out. Here is the cavity that communicates from the sole to the dorsum of the foot. Here is the necrotic bone that we saw on x-ray, which is now removed. And there's my finger with only clean tissue remaining. And after 4 weeks, he heals slowly, like this on the dorsum and this on the plantar aspect. We do see these commonly over the pressure points. We see well-rounded ulcers. When we see ulcers that are not rounded, we have to wonder about trauma. And this particular case, he has this linear ulcer almost extending in the first web space. And when we look at his footwear, we see that he has a foreign body in his slipper, a piece of bone, in fact, that is lacerating the foot. And because it has no sensation, he walks on it. 6 weeks after removal of that and debridement of the ulcer, it heals. Here is an unusual site. We look between the fourth and fifth toes to get infection. When you do that again, you must look for all the possible causes. And here this guy has a piece of metal stuck in his slipper that's lacerating his foot between the fourth and fifth toes. Here's another case. It's unusual. What can produce trauma there? Almost nothing you can think of. But when you look at his footwear, he's wearing this slipper. And this is a sharp edge that's cutting between his first and second toes. We described the slipping slipper sign several years ago. This is a mark of neuropathy. And if a patient has a slipping slipper sign, about 75% have, this is a warning in 75% of cases that they face the possibility of limb loss. It's unusual that you see multiple sites like this. And when you see multiple sites with no obvious pressure point, you have to think about other external trauma. And this is a case of rat bite in the diabetic foot, actually. Here you can see teeth marks of the rat. Rats love to bite at diabetic feet. They seem to be sweeter, and the patients do not feel it because they have neuropathy. They also can injure the foot with hot water, and one should not use warm water to clean a diabetic foot. They can also walk on hot surfaces and burn their feet without feeling it. So one's got to be aware of this as well. They can injure the foot with thumbtacks stuck in the foot, and we've had a couple of patients walking around thumbtacks in the foot for a few days without recognizing it. The other thing is in bandaging the foot, one may apply bandages too tight. And here's a patient who has a toe problem, but the bandage that is applied injures the foot and in fact could place this patient at a risk of limb loss. The other cause, in about 20% of cases, amputations are due to a loss of blood flow. And you can get a blood flow occlusion causing coldness, a dry, shrunken, shriveled foot that's not warm. And we can do tests to establish there's a deficiency in flow. Here's a good pulse wave, here it's a diminished. Here we measure the pulse volume, and here's a diminished pulse volume, and here's a normal volume. They can have occlusions at the aortic level and at the iliac level, then down at the femoral level. We can bypass these. Here's a bypass from the aorta to the iliacs. This is a bypass of an iliac. Here's an iliac occlusion. Here is an occlusion of the femoral artery, and it reconstitutes at the popliteal. So we have to bypass from the groin down to just above the knee. Here we have occlusion going all the way below the knee, and whenever we go below the knee, we usually use vein as the conduit for bypass. And here is what it looks like after surgery. Here's a bypass, another bypass to a perineal artery. Here's a bypass from the groin all the way down to the foot. So we can do some very long bypasses like this for limb salvage. Sometimes, and in fact, common in diabetes, we have a good proximal arterial flow and the tibial leg vessels are blocked. For example, here, this is an excellent flow all the way down the thigh, down to below the knee, and we get the occlusion right there. And then it reconstitutes right down at the foot. So we have to bypass from below the knee to the foot. So here's a below knee bypass down to the foot. And this patient, this is how it looks afterwards. And this heals in 2 weeks. So the amputation story in Trinidad is not very good. 73%, almost 3/4 of them have an infection. About 75% of them have a slipping slipper sign, should be a good warning sign. Sadly, about 50% of them have never been counseled on foot care. They use a lot of home remedies, a lot walk barefooted, and 40% have no regular foot inspection. The standard preventative measures we should use are proper fitting shoes, wearing shoes at all times, and so on, good foot care. And an important thing that's deficient is inspecting the feet every day. Thank you very much.
Thank you very much, Professor Narayan Singh. You have done a fantastic and I presume very scary presentation for a lot of persons, but it is the reality of diabetes and poor foot care. And how do you care for that diabetic foot to not reach that stage? Well, we are very lucky to have a lecturer in the School of Nursing, Dr. Parvati Sudas, who would lecture now on how do you care for the diabetic foot. Prof. Narayan Singh, I know you have joined us. I don't know if you want to say something because there's one question here, and when we have the prof, we have to utilize them.
No problem.
They're asking, and thanks for being able to be here with us. Are these feet and the calluses caused by diabetes? I know you answered the question in your presentation, but someone is still asking here, Prof. And as I have you live and direct, you can take some.
I don't get the question. Are these what?
Are these calluses, they call them callus and calluses, caused by diabetes in the foot?
They are caused by diabetic neuropathy. And with the neuropathy, the patient traumatizes the foot with more pressure on that particular point, and you get a reactive callus formation. So it's related to the neuropathy and the increased pressure at that particular point.
So Prof, I think you have answered that question very well, and I think you would have cleared up that basically it's due to the neuropathy, extra pressure being placed on that point where it's neuropathic, and it is actually going to cause further complications. Thank you very much, Prof, for taking the time.
But that's right. I see somebody else says that the diabetes doesn't cause, you can get callus without diabetes. That's true. But you are not likely to get that much callus trauma without diabetic neuropathy. But you can get callus, of course, without diabetes. I agree.
Yeah. Prof, we have pulled you out, and thanks a million for that and actually taking the time. So how do you manage that foot? How do you ensure it does not go there? We bring in another member of the professional healthcare team, Ms. Parvati Sudas, who at this point in time is going to do a presentation on managing the diabetic foot. So I pass over to Dr. Sudas, Ms. Sudas.
Good morning, everyone. I'm Dr. Parvati Sudas of the Faculty of Medical Sciences, University of the West Indies School of Advanced Nursing Education. And today I'm privileged to be presenting on the diabetic foot at the virtual health fair of the Faculty of Medical Sciences. My objectives today would be to define the diabetic foot, to outline nursing management approach, and to identify some limitations. Diabetes is a systematic disease caused by both genetic and environmental factors. The WHO defined the diabetic foot as a foot affected by ulceration that is associated with neuropathy and or peripheral arterial disease of the lower limb. The International Diabetes Federation has ranked North America and the Caribbean as one of the regions for the highest prevalence of diabetes, 13% in their 2019 report. The presence of hyperglycemia, neuropathy, angiopathy, and immune paresis predispose patients living with diabetes to infection of the lower limb. A total of 3,586 major lower limb amputations were performed in Trinidad and Tobago over a 7-year period, studied at 5 public institutions. With diabetes and peripheral vascular disease continue to be the major risk factors. Islam et al. 2021. 15 amputations and diabetic patients were done at the Scarborough General Hospital up to the 30th of April 2018. In 2015, there were 51 amputations. In 2016, there were 46 amputations. And in 2017, there were 47 amputations at the Scarborough General Hospital. Professor Carrington stated that the prevalence of diabetes in Trinidad and Tobago was estimated to be 14.5%, with approximately 90% of patients having type 2 and approximately 140,000 persons between the ages of 20 to 69 living with this condition. Professor Carrington revealed this data at the opening of the 4th Annual Family Medicine Conference 2018 in Tobago. However, this complications is preventable with adequate patient knowledge and practice regarding diabetes, foot ulcer, and foot care. The importance of the diabetic foot was considered as one of the main objectives of the Healthy People 2010 to reduce the incidence of foot ulceration. The nursing care of the diabetic foot will be based on the nursing process. And the history, assessment, intervention, and evaluation will be discussed. History taking. Risk factors must be known and monitored to prevent diabetic foot complications. So during the admission process, the nurse will complete the assessment form identifying all of the modifiable risk factors, past medical history, past surgical history, before she can plan intervention or even to conduct an assessment. The at-risk patient is defined as a patient with diabetes who does not have an active foot ulcer, but who has peripheral neuropathy with or without the presence of foot deformity or peripheral artery disease. All persons with diabetes should have their feet examined at least once a year and notice risk factors more often. The most important risk factors include peripheral neuropathy, peripheral vascular disease, foot deformity, previous foot ulceration, and amputation of the foot or and leg. In addition, current abrasions or recent minor abrasions, bullae, various irritation, calluses, improper cutting with toenail, fungal infection, poor foot hygiene, appropriate footwear use, and bad metabolic control are the most common causes of foot ulceration. With these changes, feet are easier to become traumatized and wound heals slowly, which increase the risk of infection. Under examination assessment, it is the responsibility of every health professional involved in the care of the person with diabetes to ensure their foot and footwear are examined at least once per year, including the care of the feet. The examination should be more frequent for those at risk of ulceration. Documentation should be carefully recorded. During screening, the identification of the foot or high-risk factors for diabetes complication is key in preventing amputation. The primary goal of screening is early detection of problems, identifying those at risk, and planning to reduce the risk of ulcers and amputation. Foot examination should include examination of the limb, movement, the healthy status of the limb, presence of moisture, the color of the limb, temperature, edema, pain, and sensation of the foot. Including will be limping, patient pain at rest, and palpation of the foot pulses. The bone condition, hammer toe, or any other abnormality that is seen during the examination. Nurses can also teach patients how to perform physical examination on their feet daily. For instance, nurses can encourage patients to carry out a series of simple rules in order to prevent foot ulcer or recurrence, such as checking the toes, every day, examining the feet, the sole of the feet, even checking the shoes before wearing them, and ensuring that the skin and the nails are well taken care of. Active participation of patients and family members must be encouraged. On the intervention, the improvement of patient care and health services are one of the most important challenges for nurses. According to World Health Organization, nurses are one of the largest health groups in the world who are involved at different levels of health. Obviously, there are several reasons for the presence of the nurse in the healthcare team, but in general, their major role or goal include health promotion, prevention of diseases, patient care, and verifying patients' compliance. Nurses combine science and art to provide health services, and since patient care is the first duty of the nurse, they play an important role in the care of the diabetic patient or the person living with diabetes. Sufficient and appropriate foot care education must be provided in order to ensure that people with diabetes know how to care for their feet. Education should be simple, relevant, consistent, and repeated at every interaction with the patient or their relatives. Lack of proper education and awareness of regular foot care contributes to the causes of foot problems. Nurses have an effective role in prevention of foot ulcer and lower limb amputation by educational intervention, screening, and providing care such as foot examination and wound dressing. However, the most important prevention of diabetic foot problem is the repeated education that should occur at every healthcare visit. Diabetic foot examination should be part of all visits. Can't emphasize that enough. Nurse should ask patients to remove their feet and socks and then examine the feet. In order to control modifiable risk factors, all patients with diabetes should be examined at least once a year for foot problems, and those at risk should be examined every 3 to 6 months as previously identified. The main element of diabetic foot management for patient at risk is a regular examination. Cannot emphasize that enough. Education of the family, of the patient, management of non-ulcerative pathologies, and management of the diabetic foot ulcer. 5 key elements for the prevention of foot problem in people with diabetes are identification of the at-risk foot, regular inspection and examination of the at-risk foot, education to patients, family, and healthcare providers, routine wearing of appropriate footwear, and pre-treatment of pre-ulcerative sites. So the nurse is an important part of the whole diabetes management team. Another part of the duty of the nurse include appropriate dressing according to the type of ulcer. Selection dressing depends on the type of the wound, which is either wet or dry, and is very important since dressing while keeping the wound clean and maintaining the wound moisture helps to reduce infection. Diabetic patient follow-up at regular intervals should be part of the care plan. According to all diabetes, should be referred to the diabetic clinic in order to be evaluated for diagnostic and comprehensive foot care every year. As already identified, daily foot care of some patients with limited vision due to diabetes and other chronic disease are difficult because they are not able to evaluate their feet. However, relatives can assist in this area, and also the use of magnifying glasses can be done during inspection of the feet at every day. Peripheral vascular disease, decreased foot sensation in combination and delay wound healing. These complications should be evaluated by the nurse both at the clinic and during home visiting. The role of the nurse in rehabilitation. One of the nurse duties is helping patients with diabetic foot ulcer to have movement. This is vital, especially for patients who would have lost their foot or limb. Nurses should encourage and assist patients to maintain their mobility with the use of assisted device based on the patient's condition. In a related study, Alia et al. Investigated the role of the nurse in the prevention and treatment of the diabetic foot and reported that patients see nurses as teachers in matters such as prevention of the diabetic foot problem, preventative care, and prevention of wounds to the feet. In light of these studies, nurses should have sufficient knowledge and skills about the topic, but nurses generally are not trained in diabetic foot care in Trinidad and Tobago. During the COVID-19 pandemic, Trinidad and Tobago public health sector had several human resource challenges. The main challenges related to absolute shortage in number of staff, skill set, and the distribution of healthcare workers, including nurses. Retired nurses were hired to complement the staff. Several attempts at training were held by the International Diabetes Federation and the North American Region for Caribbean Nurses and Nutritionists, the Trinidad and Tobago Health Science Initiative and the Johns Hopkins Medical International, the Michener Institute of Canada via COSTAT in various regional authorities. CAFA has also hosted training for health professionals to support the implementation of these guidelines in their respective countries. Almawi Limited, the holistic clinic, has formed an alliance with the Diabetes Association of Trinidad and Tobago to assist in providing foot health for members of the association. However, while diabetic foot disease is common, implementation of a strategy to improve care of the feet is required. Dr. Agatha Carrington added that the community health workers should be trained to assist in providing diabetes care and education through their understanding of the community's language, cultural beliefs and traditions, and barriers to care. Community health workers can help healthcare professionals and their patients achieve more effective prevention and management. The COVID-19 pandemic has disrupted services for the prevention and treatment of NCDs at clinics. Telehealth was utilized and patients were contacted to collect prescriptions only. This would be a major factor in looking at diabetes management and for disease over the next couple of months. Under some limitations that were advised, even though nurses now have many roles to perform, studies reveal that some barriers to preventing nursing from performing these roles, and only one facilitator have been identified in the literature that allowed them to perform such roles. Several studies reveal that the nurses lacked knowledge in specific areas of diabetes. Additionally, there is evidence suggesting that the nurses do not have training regarding foot care. And although, as previously identified, lots of training would have been done, many of these nurses would have been retired by now, and specific to foot care would not have been the priority at these training sessions. There's also some evidence supporting that one of the barriers nurses had to face was lack of resources. O'Connor et al. Identified that the barriers nurses encountered to implement diabetes care were the lack of equipment, lack of space, and lack of IT equipment in terms of evidence-based information. A study by Rupnaranjing et al., in which a majority of the participants were healthcare professionals, including nurses, identified available resources as a main limitation. Another important barrier in caring for the diabetic patients is time. Nurses indicate that time constraints were one of the biggest challenges in providing support and effective treatment or management. Joshi et al. Investigated school nurse perception of what inhibited them in teaching patients about diabetes and its management, and whether using technology or outcome and enhance those barriers. The results show that the nurse participants indicate that time constraints were one of their biggest challenges. The lack of access to specific diabetes education was another major problem encountered. Furthermore, another study also found that nurses said having inadequate time to screen for complication was an important barrier to giving that optimum care. In summary, intensive patient education for diabetic foot care by nurses has helped prevent diabetic foot ulceration and decrease amputation rates. Montenero and Soares et al. 2017. Peripheral neuropathy and peripheral vascular disease creates an unfortunate environment for ulceration and infection of the foot, which may lead to amputation. It is vital that nurses and other healthcare professionals know about the pathology, risk factors, assessment, and treatment of the diabetic foot. Imparting good foot care education to patients is a necessity. Nigaman Knight, 2017. Nurses' participation in diabetic foot care and foot examination can be achieved by increasing their awareness of foot problem and formation of diabetic foot ulcers. Training in diabetic foot ulcers is a must. Several studies show that nurses should play an active role in the foot examination, but they do not have enough knowledge about foot examination, and they do not have sufficient time to enhance foot examination. This therefore is an opportunity for School of Nursing at the University of the West Indies and other institutions to highlight or to conduct short courses identifying some of these specific areas for training for healthcare professionals. It's an opportunity that is really necessary and should be taken up by several of these organizations. These are my references. I thank you for this opportunity to share with you. Have a good day.
And sorry, there we go again, I'm muted. Thank you very much, Dr. Sudas, for a fantastic presentation. Coming up next, we have Dr. Yuri Clement, who is a professor of pharmacology, who is going to discuss with you guys the use of herbal products and herbal medicines in the treatment of diabetes. There's a lot of problems when it comes to use of herbal medicines, and there's a lot of scientific research that has gone into the use of herbal medicines in the treatment of diabetes. So I'm going to pass over now to Professor Yuri Clement, who is going to describe to you all some of those lessons. Now, please take some good notes because we have some further giveaways. And just to let you know, at the end of this session, we have a hamper from Massey and 4 vouchers from Rituals to give away coming out of this. So take some good notes in these sessions going forward. Thanks very much. And I pass over now to Professor Clement.
Good day. My name is Yuri Clement, Professor of Pharmacology, and I'm here with you for a few minutes today to talk about herbal medicines and diabetes, their uses and dangers. So before I start, I just want to give you an overview of what I'm going to talk about. Diabetes prevalent in Trinidad and Tobago, we are at a very bad state. What are the targets for controlling diabetes and blood sugar? What are the dangers of long-term uncontrolled blood sugar? And they are linked. If you don't control blood sugar, there's a high likelihood of you developing serious problems in the long term. We all know that there are herbs available for diabetes, and people in Trinidad use them quite often. So we have to look at the evidence, and before we do that, we have to ask a few questions of ourselves before we start using herbs. We're going to look at some herbs where there's evidence for, and there are not many herbs with evidence that we could look at and say definitively that these herbs are going to have a positive effect on, for example, your sugar levels or your control. We're going to look at some challenges with the use of herbs, and I'm going to point you in the direction where you can get some evidence going forward. So in Trinidad and Tobago, we have a very dire situation where about 120 people are living with diabetes. And that converts to about 13 in every 100 adults living with diabetes. And we see from the table, people with diabetes, they are most often overweight or obese, and they also have a lot of physical inactivity. We will see in the chart, there's a trend of increasing prevalence, where 1980 was about 5%, and now is 13%. So there's an increasing number of people who are being diagnosed with diabetes. Diabetes is the third leading cause of death in Trinidad and Tobago after cardiovascular disease and cancer. And of course, men more than women die of either diabetes or high blood sugar. And we know that in diabetics, we need to control our blood sugar. And that would mean the fasting blood sugar should be less than 100 milligram per deciliter, or around 100. And anytime during the day after eating, no more than 200 milligram per deciliter. And in the long term, we should have your HbA1c less than 7%. But a few small studies have shown that as far as control is concerned, it's very bad in Trinidad and Tobago. So the first study was in about 400 people, and they showed that just about 37% of them had HbA1c less than 7%, which is poor. And another study, a little smaller, about 120 patients with metformin only, just over 40% had HbA1c less than 7%. So therefore, there are a number of things when you are diagnosed with diabetes. There are a number of approaches. The first approach really is to change your lifestyle habits. So diet is one thing, cutting carbohydrates, cutting the total amount of calories intake, losing weight. As we said before, many diabetics are overweight or obese, and weight loss can help in reducing your blood sugar and improving your outcome. Also increasing exercise. We know that exercise increases insulin sensitivity, and therefore it's a part of the approach to manage diabetes. Of course, cutting out smoking, reducing alcohol, and very important, monitoring your blood sugar. We know that monitoring your blood sugar will give you an idea where you are at and what changes you may need to take almost immediately. So if you get up this morning and your blood sugar is 150, you know, last night I had 3 mangoes, I had 2 bananas, and therefore that might not be the way to go forward. And therefore monitoring sugar levels regularly can help you manage in terms of your diet. And it's a big problem because a lot of people are not taking these habits, these lifestyle changing habits seriously, and therefore they have long-term uncontrolled diabetes. On top of that approach of changing their lifestyle, we also have drug treatment, and we have metformin as a first-line treatment. And most patients, type 2 diabetic patients, will be started on metformin, and other drugs are added on depending on what level your blood sugar is at. And of course, lastly, you have insulin being added for people who have type 2 diabetes whose blood sugar is very out of control. But the big problem again is that many people are not taking their medications as they are prescribed. So there's a danger of having a long-term damage because of high levels of blood sugar over sometimes many years. And that can lead to damage in the small blood vessels in the eyes, in the retina, where it could become detached. You could actually lose your vision because of prolonged high sugar levels It could also, in the kidneys, cause kidney damage that could lead to kidney disease and kidney failure, where you may need to get dialysis or eventually get a kidney transplant, and also could cause problems with your sensation in the extremities, in your hands and in your feet, which could lead to you getting amputations in the long run. There's also damage in the large blood vessels, in the brain, in the heart, in the legs that lead into stroke, heart attacks, and clogged arteries in the legs and feet. So many people, and remember we said before that many people are not compliant or do not adhere to the approaches in terms of diet, in terms of medication, and sometimes they believe that using herbs might work. And there are about 50 or so of herbs that have been documented to be used for diabetes in Trinidad. We have Coriander, aloe vera, periwinkle, neem, garlic, ginseng, just to name a few. And studies in Trinidad have shown that about 25% of people with diabetes would use herbs, not only for diabetes, but for maintaining health. And they have found also that about 10% of these people with diabetes would use herbs to treat their symptoms. But we do need to ask some important questions when it comes to using herbs for diabetes and for controlling blood sugar. The first question we should ask is this herb actually reducing my blood sugar? And the second question we should ask is, to what extent would this herb reduce my blood sugar? And we have measurements. We said the fasting blood sugar and the HbA1c are two good measures of that. So is it reducing my fasting blood sugar when I get up in the morning? If my blood sugar is 150, would it reduce it to 110 or 100? Or if my HbA1c is 8.5, would it reduce it to 7 if I use this herb in the long term? So those are questions that we should be asking ourselves. We should also be asking ourselves, could I take these herbs together with my doctor prescribed medicine? And if I'm taking it over the long term, is it that there's going to be some interaction? Because I don't know, maybe I might get dizzy, maybe I might have nausea and vomiting, I don't know. But is it safe to be able to take these medications, my medication together with these herbs? And in some cases, there are people who actually replace their doctor prescribed medicines with herbs. And in that case, is it safe? Would it bring my blood sugar down to the point where I don't need to take my medication? Or is it that I'm putting myself at risk for having prolonged high blood sugar levels that would predispose me to have damage to my eyes and my kidneys and get a heart attack or a stroke? So all of these are questions that we need to ask ourselves before we start using herbal medicine. So even if you're using it now, these are questions that we should be asking ourselves. So a lot of the times what we get is what they call anecdotal evidence, meaning that somebody tells us a story about something, or we read something on the internet, or we get a video saying that use this or use that, and somebody who claims to be a scientist is telling you that I have proof that this herb is going to work. But is that sufficient? Is that enough for us to say that we have strong evidence for this? In science, in medicine, the gold standard for the evidence is the randomized controlled clinical trial. In this trial, you have a sufficient amount of people who are randomized to receive either the treatment, in this case the herb, or a placebo, which we can say the control group. You take measurements before you start the experiment. So in this case, for diabetes, you take measurements of fasting blood sugar and also measurement for HbA1c, which gives you an idea of long-term control. You give your treatment over some time and you follow them up, and at whatever time the experiment ends, you will take those same measurements and you will compare, and you will determine whether there's really a difference between those two, between the treatment group and the control group. And this design of study really improve the quality that we get, because it means that it is the size is big enough. It's not one person coming and telling me I use this, or somebody on the internet say I'm using this, but it's a large enough study that's comparing two groups, the treatment group and the placebo group or the control group. And it's telling me now at the end of the day that I'm getting a difference between the treatment and the placebo. So normally you will have more than one study for a herb. You might have 10, 20, 30, whatever that number. And there are people who would now review whatever data they get from those studies in what they call a systematic review. So I might have 10 studies with 1,000 patients, and that now gives my evidence more credibility. It can now stand on its own legs and say for sure that this is working. And therefore I have my systematic review of those herbs, and that will give me some idea whether these herbs are working. And on top of that, I have my meta-analysis, which actually gives me a number. It tells me compared to my placebo that my herb is now reducing my fasting blood sugar by 20 milligrams per deciliter, or decreasing my HbA1c by 0.5% over the period of the study. And therefore that now gives me more solid evidence as opposed to somebody just saying that I'm using this and it's working. So there's a pyramid of evidence, and that pyramid of evidence is at the top of it is the meta-analysis, with information that's coming from these randomized control studies that feed into the systematic review that gives me an idea about the totality of the evidence that I have before me. And therefore now I'm more confident in believing or holding fast to what that evidence is saying. So this morning or today, we're just going to look at a few of them. We don't have time to look at many. So we're going to look at Karayli, which is more Modica, Charantia, aloe vera, moringa, gymnema, cinnamon, turmeric, and garlic. So Karayli have been around for a long time, and there was one review done in 2019 with 10 studies, just over 1,000 patients. The studies were between 4 and 16 weeks, and they found that fasting blood sugar decreased by 13 milligrams per deciliter and HbA1c by 0.26%. All right, that might seem good, but remember we said previously that we have targets, and targets for fasting blood sugar, targets for what we have during the daytime, and targets for HbA1c. So for example, if my fasting blood sugar is 140, and my target is 100, and I take this Karayli and it goes down by 13, is that carrying me to where I need to be? That's the question we need to ask. If my HbA1c is 8.5 and Karayli is taking it down by 0.26%, am I any closer to 7% where I need to be? And therefore that's some of the questions we should be asking when we're considering adding a herb or replacing a herb with doctor-prescribed medicine, which has been proven to work. And in this review, the reviewers found that there was a low quality of evidence because there were a number of things in the design of the study that were lacking. For aloe vera now, we see that there were 2 reviews, and the 2 reviews, we see that they were quite small, one with 400 patients, one with under 300 patients, but we see that the results look very fantastic. The first one, fasting blood sugar going down by 30 milligrams per deciliter. The second one, fasting blood sugar going down by almost 47 milligrams per deciliter. So those look like very fantastic results. But we have to remember that these are very small studies. And reviewers in the first one said that the numbers were quite small and the quality was also poor. And therefore, even though we have these fantastic results, these results are inconclusive. And they recommend that there's a need for large-scale, better designed randomized controlled trials to really support these findings. So it looks good, but there's a question mark over that. So cinnamon already have been used, we know have been used, and there's a resurgence in the use of cinnamon. And there are 18 trials so far up to 2018, and fasting blood sugar goes down by about 20 milligrams per deciliter, and there is a minimal decrease in HbA1c of 0.24% over the long term. And therefore, as I said previously, we have to take all of this into consideration when we want to use these herbs, or we want to add them on to conventional drugs, or replace them with the conventional drugs. And therefore, we have to be careful and mindful that the effects sometimes are minimal. We now come to turmeric, and in 2019 that there were 7 studies, and they showed a significant reduction in fasting blood sugar, but there's nothing in this report that talks about HbA1c, which is more long-term control. Garlic, this is one of the larger reviews, 33 trials with about 1,300 patients being included, and they found that garlic would reduce fasting blood glucose by about 11 milligrams per deciliter, which is moderate, which is not to the large extent that you want it in terms of if you are very seriously uncontrolled. So moringa has been around for a long time. There are not many studies done, very small study. You see all of these studies here, 1, 2, 3, 2016, 17, and 18. 10 healthy volunteers, 32 type 2 patients without treatment, and 17 diabetics, and 10 healthy volunteers. These studies are, the first study was poorly designed because there was no glucose challenge, even though they are measuring blood glucose and insulin after giving the moringa powder. So that's a major flaw, and therefore we don't know how reliable those results are. The second study, after 4 weeks with 8 grams of the powder, there's no effect on glycemic control. And the third study, there's a decrease in absorption of glucose in diabetic patients. Remember, these are all very small studies. So in summary, for moringa, the evidence suggests that it may increase insulin secretion, but as I said before, the studies are very poorly designed. It may decrease glucose absorption in diabetics, and on the other hand, it showed that there was no effect on glycemic control. So these are very small studies. 2 of them are intervention, but just only a one-time intervention, and therefore there is no systematic review, there is no meta-analysis, and therefore the data from those studies cannot be used to say we have sufficient evidence to use moringa in diabetes. The next one we have is Gymnema sylvestri, which has been used for centuries in Ayurvedic medicine, and in Hindu, the Hindu term for it means sugar destroyer. But like moringa, Gymnema, there's very little evidence, very little work done. The first 2 were done in 1990, which is over 30 years old. In small number of patients, the first one looked at type 1 diabetic patients on insulin, under 20 patients, given 400 milligrams per day over 12 months, and we saw that decrease in requirement for insulin, decreased fasting blood glucose, and decreased HbA1c. Our second study was done in 22 type 2 diabetic patients on drug therapy, 400 milligrams per day for up to 20 months. We had fasting blood sugar, HbA1c decreasing, and the level of insulin endogenous being secreted increasing. And that study, 5 of the patients were able to discontinue their drug therapy because they were able to maintain their blood sugars with the extract only. In the last study, which is the more recent study, there was no effect whatsoever with 600 milligrams per day on either insulin secretion or insulin sensitivity. And therefore, Gymnema, although it has been around for centuries, the evidence is very weak, and there is a need to have larger studies over the longer periods so that we get the evidence to say whether it works or not. So in summary, we have the strongest evidence coming really from kauri, cinnamon, and garlic. And we see that in all of them, that the fasting blood sugar levels decreasing marginally, not more than 20 milligrams per deciliter, and the HbA1c decreasing also marginally, just about 0.25%. And that really means that you cannot replace your doctor prescribed medicine with these herbs because it would not bring your blood sugar down to where it should be. So in conclusion, we would say that these herbs are safe in the short term because in these studies, none of the researchers found that there was any problem, any adverse effects in the short term. We do not know what will happen in the long term. The limited evidence suggests that these herbs, some of these herbs may lower blood sugar, reduce insulin resistance, and may improve long-term glycemic control by measuring HbA1c, but these effects are just modest. And therefore, if these herbs should be used at all, they should be used as supplements, and supplements to lifestyle changes. Remember, we talk about diet and reducing carb intake and reducing total calorie intake and losing weight and exercising. So these herbs must be added onto the lifestyle changes as well as added on to the drugs that are being proven to work. So we do have some challenges with these herbs. A lot of the times we don't know what we are taking, or the amount we are taking, or whether the active ingredient and how much of the active ingredient is in the herb that we are taking. So therefore, that's a whole different ball game when we talk about herbs. We don't know what the active ingredient is. Sometimes we don't know how much of it is taken in when we take it, in whatever form we take it. We don't know sometimes when we take it, whether we are using the prescribed drug, whether there's any interaction that could be dangerous, that could be have serious side effects, and that's something that we should also be aware of. So I just looked at a few herbs today, and there may be others that are in use, and I just want to point you in a direction of where we can get information. And one of the places that we can get it is an NIH site in the US called the National Center for Complementary and Integrative Health. And that website will provide objective evidence on herbs. You will find some of what I've spoken about on this website and others that are also used for diabetes. And that will really give you a sense of the evidence that is available for the use of herbs in diabetes. So thank you very much for your time. And I hope that we come away with some benefit. Thank you.
Thank you very much, Professor Clement. And, we are very, very happy that you were able to give an evidence-based view to the use of herbal products in Trinidad and Tobago, and you have dealt with some of the more common and relevant herbs utilized. So, Prof, we got someone is asking if you could share slide 4 again whenever you have some time. They said they found it to be very eye-opening. And what we'll do, we'll share the recording as well after of these proceeds on our social media pages, and we'll email everyone the link to that. Now for the questions, I think, did we announce the winner? Yes, we did announce the winner right after lunch of the last section. So this time we do have a hamper, as I said, courtesy Massey, and I have four vouchers courtesy Rituals worth $200 each, and this is for the healthy stuff at Rituals. You all will get. So it's for the purchase of healthy stuff. They got a new healthy brand of stuff that Rituals is offering, and hence the question is going to come now. So there's no place to say, we don't type the question in, but Professor Narayan Singh alluded to the cost, the approximate cost of diabetic foot issues to the healthcare system in Trinidad and Tobago. The first person will get the hamper, and the other 4 persons will get the other 4 correct answers will get the voucher. So I'm seeing numerous answers coming in, and I will leave you through the lunchtime period to place, and I repeat that, the cost to the Trinidad and Tobago health system. So I will leave you through a lunchtime, and we are just giving, we start back at 12:30 promptly. We'll start back at 12:30 promptly to have our prize giveaways, as well as some very, very interesting lectures going forward. Hi, and we are very happy. Hope you had a very short and refreshing lunch. So there are about 260 people that are still in the prize for winning that trip to Tobago and that hotel stay. And our next speaker, you would have seen that lovely One Health video. And we are lucky to have a real COVID expert in our midst. None other than Professor Chris Ora, who has also, like our dean, been ranked among the top 2% in the world. And Professor Ora is a professor of virology, and it is all about interprofessional help, interprofessional connections. And coming out of our interprofessional team, I will now pass over to Marketing and Communications, who will bring Professor Chris Ora on to us. And I will give the winners very soon for those who have questions. But before I do that, over to Professor Chris Ora. Mark.
A very good day to everybody. So I'm going to be talking today just for 15 minutes about really the background behind COVID-19 and bringing in other pandemics. So what I'm going to be talking about, or what I plan to talk about today, is these questions we see on the left here. Why are we seeing more pandemics over recent years? Why is the situation getting worse? And critically, what can we do about it? And of course, the $6 million question is, how can we prevent the next pandemic? Now, I don't say that I'm going to answer all these questions. I'm just going to give you some pointers, at least. So I think it's important to start off by saying that 75% of recently emerging infectious diseases that affect humans began as animal diseases. So we have a lot of diseases, the majority of diseases that we know as humans have actually come to us through animals. Some have come to us directly from wildlife to humans, some from livestock to humans, and some from both wildlife and livestock to humans. So I like to start off talks with key take-home messages. So my first take-home message is that domestic animals and wildlife do play a very important role in spreading viruses to humans, as I've just said. However, there is a single species that is responsible for this, and that's human beings, that's us. And recent pandemics like COVID-19 and like other pandemics we've seen, such as the swine flu pandemic, are a direct consequence of human activity. And we must not blame wildlife. Wildlife do a massive amount of good to maintain our ecosystems. We must protect and preserve them. We need to change our habits and our customs so we live in harmony with animals and wildlife. We must learn from our experiences in previous pandemics. We must look back and we must learn, or worse will happen. And this is really not if, when, because all the conditions are in place now for things to get worse unless we do something. And I'll point out some of those conditions in a little bit. And finally, and very importantly, we need to follow a One Health approach. As clearly we understand that everything is connected. The health of us, the health of our animals, the health of our environment, the health of our plants are all inextricably and intricately linked. If we affect one, we affect the other. And we must recognize these connections if we're going to go about addressing these issues and mitigating these issues in an efficient way that is going to maintain our ecosystems and is going to save our planet. And critically, here is what was said by top scientists: halt destruction of nature or suffer even worse pandemics. And this is really the bottom line. So when I show this slide to my students. I say, look at all these viruses here. What do they have in common? We all know these viruses very well in the Caribbean. We know dengue, we live with dengue. Of course, HIV, which is a big issue. And then we have the coronaviruses, SARS virus, SARS-1, and MERS viruses, which have emerged around the world. We've suffered, many of us, from chikungunya virus with arthritis. And of course, we had the big scare and continue to have scares with Ebola virus. And then, of course, there's Zika virus, which affected so many of our pregnant women, causing the severe disabilities in young babies. So all these viruses here have come through animals. And I say to my students, which one do you think is next? And when I ask that question, I always think, I'm afraid, about influenza, because influenza has an amazing way of varying and changing. It has unique abilities to change its genome and shuffle around its genome so it can gain the ability to jump from species to species. So influenza is really the prime contender for causing future pandemics. And we're all expecting an influenza pandemic to appear at any time. And then, of course, we got COVID-19, which was not surprising because we'd already seen these coronaviruses, or very similar coronaviruses, appearing in SARS-1. And of course, we have it with this MERS virus. And these are subtly different viruses. SARS-1, luckily, was less transmissible than COVID-19. So in the end, following our non-pharmaceutical interventions, the sort of measures we're taking at the moment, that was enough to get rid of SARS in the end, because it was not so transmissible as this COVID-19. And MERS, of course, is less transmissible again, but both SARS and MERS are nastier. They're more virulent, they kill more people. So COVID-19 appeared, which was sort of in this sweet spot whereby it was able, because of its high transmissibility and ever increasing transmissibility, as we've seen, it's very, very difficult to actually get rid of. So what is happening? Why are these pandemics appearing, or why are more pandemics appearing in recent years? Well, it's this spillover events that I talked about just now. We have many, many viruses that are circulating very happily in wildlife species, backwards and forwards in wildlife species. That if they stayed in wildlife species, if we enabled wildlife species to remain in their habitats, we wouldn't have any problems in humans. The viruses would circulate. They often don't show any clinical signs, and we'd be all okay. However, because we are moving in closer proximity to wildlife, we're enabling those viruses to spill over and jump across. And some of these viruses that we've seen recently, for example, HIV, have jumped directly across from wildlife, as we see here, into humans. We need to try and avoid this. And some viruses like COVID-19 or some influenza viruses like swine flu, they've jumped from wildlife to domestic animals, and then they jump from domestic animals that are in close proximity to humans. And they use various vectors as well. And of course, in the Caribbean, we know very much about these vectors. We have lots of ticks, we have lots of mosquitoes, midges, we have lots of bats. So the vectors often help in the process of transmitting these viruses across from the wildlife, domestic animal interface into humans. Why is this situation getting worse? Well, over recent years, all these issues here have continued to get worse because of pressure on increased populations, pressure on poverty, people living in closer proximity to wildlife and domestic animals. So when you have deforestation and forest encroachment, you have people moving into habitats or areas where wildlife used to have as their own, and people are moving in, we can all see that those viruses in the wildlife are likely to have the opportunity to jump into humans, because the humans are moving into areas where those viruses are and those wildlife are. We also have, through a number of reasons, often driven by poverty, people, animals are in domestic animals and sometimes wildlife are in more close proximity. Here you see the chicken, you see the pig, which is extremely influential in transmitting new strains of influenza viruses because they act as a mixing bowl for these. They enable these influenza viruses to vary very dramatically and gain the ability to jump into humans. So you have these areas of the world where people are very much in close proximity to their animals, enabling these viruses to jump across. Also, viruses can jump across once the animals have been killed and the viruses are present and they're in the blood and they're in the carcasses. And if people start butchering these animals in the wrong ways, in the close proximity to blood, in unhygienic conditions, those viruses can jump across, such as in the wet markets of China, which may well have been the reason why, for example, COVID-19 jumped across from an unknown, as yet unknown, wildlife species into humans. And once they get, of course, into humans, high density human populations that we see at the moment, unplanned urbanization, enable those viruses to jump from human to human. And of course, intensive agriculture, modern agricultural practice like you see here, enable viruses to transmit very quickly from animal to animal. And once the viruses get out there, of course, they can be transmitted either through animals, through animal products, or through humans via rapid global transport networks. So we see here global hotspots. We see areas where you look to model all these different conditions here that enable viruses to jump across. You look to see where in the world these viruses are more likely to emerge from animals and get into humans. And you can see in the yellow areas here, these are the high-risk areas of the world where those conditions are in place for viruses to get across from animals into humans. And you see, of course, in China and southern China, there's a big areas, in Asia, of course, in Africa, where there are a lot of forests or a lot of areas conducive to these jumps, and of course in South America, in the rainforests and up near us in the Caribbean. And you can see in this, in yellow here, some of these hotspots are extremely close to us in the Caribbean and across into Venezuela. So, for example, putting Trinidad and Tobago at risk because viruses that emerge in these kind of areas close to Trinidad and, for example, Venezuela are likely to come across, as we know, because there's movement of people and animals across from the South American continent into Trinidad and Tobago and then onwards into the Caribbean. So don't forget our skies and our oceans and our rivers here, because these viruses are likely to cause pandemics like the influenza viruses. How do they transmit around the world? They often transmit in wild species of animals, and in this case, often for avian influenza, wild birds, where they often don't show severe clinical signs. So these viruses are able to be carried by wild birds across thousands of miles in these migratory bird flyways. So across from Asia, as you can see, across here into North America, and then down through the Caribbean into South America, and they can take the viruses with them. And these influenza viruses are transmitted actually through the feces of these birds. So they stop off at various places, like in the Caribbean, and then, of course, through they stop off, and in their feces they have these dangerous, potentially dangerous influenza viruses, and that's how they transmit them around the world. So we mustn't forget the flyways, the birds. We mustn't forget we have extremely serious situation with avian influenza at the moment, which is transmitting in many countries around the world, H5N1, which we need to have a look at very, very closely. Also, we have to think about our seas, and we have to think about regulation of our wildlife and our fish, because there's often very poor regulations of our fisheries. And here's an example of this bacteria, Edwardsella, which came in through catfish imported actually into Trinidad from West Bengal, causing a very severe disease and very dangerous disease in our fish. So we have to look at trying to stop these viruses actually coming in through all these different ways. So sadly, to finish off a little bit, climate change will only make the situation worse. With the pressures of climate change, the increased temperatures having increased transmission of vector-borne diseases, more food and waterborne issues, climate migrants moving viruses with them, we're going to get all sorts of more trouble as we move forward. So finally, what can we do about it? This is the kind of thing we want to stop. We want to stop the ability for these viruses to have the chance of getting across from wildlife or domestic animals into humans, such as stopping these wet markers. These were stopped actually after SARS-1, but then they were started again. They've been stopped now after COVID-19, but are they going to be started up again? We need to look and see where are the places that these viruses, where the high-risk areas these viruses can actually get across from animals into humans, and try and put a block on them. And blocking these wet markers is a very important first step. So how do we prevent the next pandemic? The $6 million question. We need to rethink our relationship with the natural world, which is, as we know, consumptive, intrusive, and disruptive. We have to work with governments around the world, must work together, collaborate to strengthen global health systems so they can prevent, prepare for, and respond to the next pandemic. And this is not only governments in developed worlds, this is governments in developing worlds. In order to do this, we need to invest in 3 areas. Surveillance, knowing where the viruses are, where the dangerous viruses are, so we can stop them in their tracks. Manufacturing, in both developed and developing countries, so we can produce vaccines and treatments rapidly in around the world, not just in a few countries, so we can respond so much more efficiently if we do get a pandemic. And critically, we need to promote coordinated, equitable research and development across the world. Equitable being important. We need to go to the areas where these viruses are likely to emerge from and make sure we have strong research and development practices in place. And finally, follow a One Health approach. As everything is connected, we need to remember that our health, the health of our animals, the health of our environment are intricately connected. And we need to all work together to halt the destructions of nature, to protect our ecosystems, to live in harmony with our nature and save our planet. Thank you very much for your attention, and I'd be very happy to answer any questions.
Hi, and thanks very much, Professor Ora, for a very enlightening and real health presentation. As Professor Ora has also answered some of your questions in the chat, and I really wish to thank him for taking the time to be there and be here with us. Up next, we got our lecturer in medicine, Dr. Satish Sakamori, who is going to address issues around COVID. He is going to let us know, how do you manage the COVID patient signs and symptoms? There are many people who have signs and symptoms. You don't know if it's COVID, you don't know if it's a common cold, what it is. And I'm passing over now to Dr. Sakamori to speak to you on managing COVID signs and symptoms. Dr. Sakamori.
Hi, good day. This is Dr. Satish Sakamori. I'm a lecturer in Faculty of Medical Sciences. Today, I will discuss about managing COVID-19 patient signs and symptoms. The incubation period for COVID-19 is generally within 14 days following exposure, with most cases occurring approximately 4 to 5 days after exposure. Although COVID-19 is primarily a pulmonary disease, number of organ systems can be affected with SARS-CoV-2 virus, including cardiovascular system, skin, blood, gastrointestinal and hepatic systems, neurological systems, and kidneys. In addition, these patients can suffer from several complications, including secondary bacterial infections, thromboembolic events, clot formation in the legs, lungs, and various other blood vessels can occur with COVID-19, especially in critically ill patients. The commonly seen symptoms of COVID-19 are fever, cough, tiredness, and loss of taste or smell. Occasional symptoms include sore throat, headache, body aches, diarrhea, skin rash, and red or irritated eyes. According to some studies, about 1/3 of people with SARS-CoV-2 infection never develop symptoms. However, majority of these asymptomatic patients can manifest with abnormal radiological signs. So you can see on the chest X-ray, some vague opacities are visible there. And same on the CT scan, the lung field is supposed to be dark like here, but you can see some white opacities. We call them as ground glass opacities on both sides. COVID-19 disease severity varies from asymptomatic or mild disease to critical disease. So in non-severe, the signs are mild, and you may not see the features of severe or critical disease. In severe disease, usually we see compromisation of oxygenation, which is less than 90% on room air. And these patients can also exhibit features of pneumonia. And some of them can develop severe respiratory distress. In critical group, you may see organ failures, including lung failure, cardiac, renal, blood. Several organs can fail in the critical state. And these patients need more support like ICU care, right? And these patients can develop acute respiratory distress syndrome. So which is nothing but fluid formation in the lungs due to the immunological damage. And they can also develop sepsis, which is nothing but infection associated with organ failure. And some of them can develop septic shock. The blood pressure can drop significantly. So according to the earlier studies, about 81% of COVID-19 patients suffer from mild to moderate disease, whereas 14% of the patients can present with a severe disease, and 5% of them can establish critical illness. COVID-19 disease progression. In early stages of infection, the viral load will dominate. And eventually, this load will go down with the time. However, subsequently, the patient's body will react with the immunological cells and develop excessive inflammation. Right? This uncontrolled inflammatory response can lead to critical disease and organ damage. So in early stages, most of the patients are asymptomatic or may suffer with mild symptoms. And they may show some changes in their blood counts. The lymphocytes, a type of blood cell, can go down, the counts can go down. And a neutrophilia, which is another type of white cell, so that cell counts can increase significantly. So at this stage, the patients may not need hospitalization. But some of these patients can progress to moderate or severe disease. So when the disease progresses, they may need hospitalization and eventually some oxygen support, right? So starting with the low flow oxygen and then subsequently high flow oxygen or non-invasive ventilation. So at these stages, patient may suffer from some symptoms like shortness of breath, hypoxemia, that is a low oxygen in the blood, which may need some supplemental oxygen. And at this stage, the patient may exhibit abnormal chest X-ray and inflammatory marker elevation in the blood. Some of these moderate to severe disease patients can progress to critical disease because of the excessive, uncontrolled inflammatory response of the patient body. So that can lead to several organ failures, and most importantly, acute respiratory distress syndrome. So it's nothing but an immunological insult to the lungs, which will allow the alveoli and air sacs to accumulate the fluid, so which will impair the oxygen diffusion into the blood. So at this stage, patient needs mechanical ventilatory support, or in advanced centers, we can support them with ECMO, extracorporeal membranous oxygenation support. How to manage COVID-19 patients? In mild stages, patients may not need hospitalization. So when we're managing the patients at home, isolation is very, very important. And the COVID-19 patient should maintain proper hygiene. They need to follow their doctor instructions and Ministry of Health guidelines. Nourishment, hydration, and ambulation are important as well. If these people suffer from fever or pain, they should use Panadol rather than painkillers. We also call them as non-steroidal anti-inflammatory drugs. Antibiotics should not be used routinely because the incidence of secondary bacterial infections in COVID-19 patients is not common. So antibiotics should be used judiciously when there is an appropriate indication. Similarly, systemic steroids should not be given to the patient who doesn't need oxygen support. According to the early data, steroids can cause harm to these patients, so they should be avoided. Similarly, there is no need to administer blood thinners like anticoagulants or antiplatelet drugs like aspirin. However, these patients should watch for warning signs like worsening shortness of breath or difficulty in breathing, loss of speech or mobility or confusion or chest pain. When the patients or their family members notice these warning signs, they need to call the ambulance for admission. For patients admitted in hospital, some of them may need oxygen support. So oxygen support can be given with various devices or interfaces. So usually for people who need low flow oxygen, we start with a nasal cannula, right? And for people who need more oxygen flow, we switch over to face mask. And for people who need high flow oxygen, we go to non-rebreather mask. And there is a device called high flow nasal cannula. And people who need more support, they may need non-invasive ventilatory support. So we hook up with these various masks, these interfaces like a nasal mask or a full face mask or a helmet mask, and we connect them to a machine. So the machine will push the air and oxygen with high pressure. For critically ill patients, we have to keep them on mechanical ventilator, where we pass a tube into the throat and connect to the mechanical ventilator, the machine. So the machine will usually take over the breathing function of the patient, or sometimes they support the person's breathing effort partially. In severe cases of ARDS, acute respiratory distress syndrome, we may have to ventilate those patients in prone position. So we keep them, keep them on their belly and we ventilate in that position. In some patients, mechanical ventilation can fail. So in those patients, you may need a special equipment called extracorporeal membranous oxygenation. So this is a machine that takes out the impure blood from the right heart and purifies the blood by giving oxygen and taking out the carbon dioxide, and pump the purified blood into the left heart. So that is the extracorporeal membranous oxygenation system. The medical management of COVID-19. So currently, there are 4 types of medications have been approved by the guidelines. The first group is antivirals. And the second one is antibody products. The third one is immunomodulators. And the last group is anticoagulants. Antivirals. So remdesivir is popularly known. And there are 2 new other drugs recently approved or partially approved by the regulatory agencies. Ritonavir with a combination of nirmatrelvir and molnupiravir. These are the antivirals. Antibody products. These are more for patients who are not hospitalized to reduce the disease progression. So there are 3 products are available internationally. So the first one is bamlanivimab and etesevimab. The next one is casirivimab with a combination of imdevimab. And the last one is sotrovimab. The first 2 antibody products may not be effective against the new variant, the Omicron. So based on the early studies, sotrovimab appears to be effective against Omicron variant. Immunomodulators, corticosteroids, tocilizumab or sarilumab. These are interleukin-6 antagonists, and baricitinib or tofacitinib. These are Janus kinase inhibitors. So these immunomodulators are more useful for hospitalized patients who have significant uncontrolled immune response. Anticoagulants are blood thinners. There are various types of blood thinners available. Heparin, low molecular weight heparin, warfarin, and direct oral anticoagulants. These are tablet medications, oral medications. Right? So these anticoagulants are more recommended for hospitalized patients to prevent the clot formation. So if you look at the disease progression that we have discussed earlier, antiviral therapy, especially remdesivir. Antiviral therapy should be started early preferably within 10 days of symptom onset. And some of these medications you may have to start within 5 days of symptom onset. And they're recommended for mild to moderate disease, and they may not be effective, especially remdesivir is not effective on patients on mechanical ventilator. Their benefit, especially remdesivir, may not produce any mortality benefit. In other words, it may not reduce the incidence of death. However, it may reduce the time to recovery. Antibody therapy. So these are several antibody preparations. They are more used for non-hospitalized patients. They are not recommended for hospitalized patients yet. Anti-inflammatory therapy, including corticosteroids, interleukin-6 inhibitors, and Janus kinase inhibitors. These are recommended for people who need oxygen support. Among the hospitalized patients who need oxygen support. And anticoagulants, the blood thinners, we give them a low dose to prevent the clot formation for hospitalized patients. So there are a few other drugs. We don't have adequate evidence yet to recommend them in clinical practice. One of them is fluvoxamine, which is an antidepressant medication. Few trials have shown some benefit with this medication, but the evidence is not adequate enough to use it routinely. Similarly, inhaled corticosteroids. So we use them for the management of bronchial asthma and COPD. And they have shown some benefit in some of the trials, but the data is not adequate enough to use them routinely. However, we know that some of the treatment options are not recommended. There is no benefit in using them. And they may cause more harm than benefit. Medications like chloroquine or hydroxychloroquine, ivermectin, azithromycin, interferons, immunoglobulins, colchicine, zinc, supplements like vitamin C and D, and convalescent plasma. So these medications have shown no benefit in the management of COVID-19. So they are not recommended by guidelines. The patients who recover from acute illness, that is up to 4 weeks, some of them can develop persistence of symptoms or complications. So we call this as a long COVID. You can see here, 80% of COVID-19 patients can suffer from long-term symptoms beyond 2 weeks, right? And the commonly observed symptoms are fatigue, headache, smell, lack of smell or loss of smell, anosmia, hair loss, loss of taste, and shortness of breath. So there are several symptoms can occur in these patients. And most importantly, some studies have noted that death can also occur in these long COVID patients. And these patients are at risk to develop new respiratory disease, major cardiovascular disease, chronic liver disease, chronic kidney disease, as well as diabetes. We know that COVID-19 can cause significant morbidity and mortality. Currently, we have limited options to manage these patients efficiently. We know prevention is better than suffering, and vaccination remains the most effective way to prevent COVID-19. Thank you very much for your time.
Pleasant good afternoon. And again, I'm talking to myself. Two things I wish to do now. One is announce the winners for the last grouping of questions, and the answer was 595 million TT dollars are spent yearly on dealing with the diabetic foot. And the winner of the hamper from Massey is Nived Sahadeo, and winners of the vouchers are Miss Vanessa. Sorry. I messed this up. The winner of the hamper, is Lynn Neal Harry. Sorry, Mr. Sadio, Miss Lynn Neal Harry. And the winners of the vouchers are Mr. Nived Sahadeo, Miss Vanessa Jagannath, Geneva Smith, and Beverly Ann Ali. So congratulations to those 5 people. Could you all please send your information to Miss Ramdas to ensure that she has that information to be able to get in contact with you? You need email, ID, address, and so on. Dr. Sakamori, there are some questions in the chat that I hope you could attend to that persons are asking at this point in time. And we have our final presentation, because we do know COVID, and this issue has come up in the chat, has brought mental health issues, and it's something that needs to be managed well, and an area that we usually neglect. But we are very lucky to have our Deputy Dean Clinical Sciences, Senior Lecturer in the Department of Clinical Medicine, Dr. Sandra Reed, who will be now doing the presentation on managing your mental health in the COVID pandemic. Over to Dr. Reed. Thanks.
A pleasant day to all of you logged on for this presentation. I would like to share with you my pandemic watchwords. Be kind to your mind. What does that mean? It's about managing your mental health during these very difficult times. The COVID-19 pandemic has brought an unprecedented onslaught of stress, illness and death, fear and uncertainty, family and financial struggles, and just the absence of peace of mind. This has resulted in increasing levels of anxiety and depression in the society. A national survey done in Trinidad and Tobago in July of 2020 showed that 47% of persons reported feeling anxious at least several days in the prior 2 weeks. This number increased to 60% when the survey was repeated in June of 2021. Similarly, in 2020, 44% of persons reported feeling down, helpless, or depressed, and this number increased to 66% in the following year. What does that tell us? It tells us that alongside the COVID-19 pandemic is a pandemic of mental health issues that deserves our attention. There is nothing scary or stigmatizing about anxiety and depression. In fact, these are very normal responses to some of our personal life experiences and what is going on around us. We need to be able to cope with these feelings, and that is what determines if we have good mental health. When we talk about good mental health, we do not mean that you should never feel anxious or depressed. We are referring to your ability to cope with these feelings. Let's reflect a little about what can happen when we are under a lot of stress and begin to feel overwhelmed, anxious, or depressed. Take a second and reflect for a moment. How do you react? What do you do? Maybe you've lost your job, or you are scarcely managing to keep your job while juggling home and online school for your children. Or perhaps you've lost multiple relatives to COVID-19, one after the other, and you're scared because you know that you have underlying medical comorbidities. How do you feel? And what do you do with your feelings? I will tell you what people commonly do. Some try to sweep their feelings under the carpet. They don't even express how they feel because they are ashamed of the feelings. They think that they are weak. But Sigmund Freud said, unexpressed emotions will never die. They are buried alive and will come forth later in uglier ways. So individuals who suppress tend to experience a lot of physical symptoms. The list is long, ranging from anxiety to headaches, asthma, ulcers, acne, hypertension, poor diabetic control, low back pain, fatigue, insomnia, impaired memory, and a range of other psychosomatic symptoms. That's not good management of your mental health. That is not being kind to your mind. Then there are others who refuse to feel at all. They try to block out the stress by feel-good behaviors that stimulate the mesocorticolimbic circuitry of the brain. That's the scientific term for the pleasure center of the brain. Their choices result in pleasure, but it's only temporary. The bad news is that for many, these become fixed habits, which do not help to cope with the stress and eventually result in a whole lot of adverse consequences and even more problems. What are some examples of such behaviors? Some may actually surprise you. We could guess, for example, that the use of alcohol and drugs is a common one, but people also overeat and gamble, sex and pornography, overworking, excessive exercise, and shopping. Reliance on and addiction to these behaviors are also not being kind to your mind and do not make for optimal mental health. And then we have those who just worry. They easily give up hope, see it only the negatives and drowning in pessimism. And the more they worry, the more anxious they get. You would agree that that is unkind to the mind. Those are examples of poor coping that only results in more distress and dysfunction. On the other hand, according to a report of the US Surgeon General, good mental health is the ability to think, feel, and behave in a manner that results in productive activities, fulfilling relationships with others, and the ability to adapt to change and to cope with adversity. In other words, as the World Health Organization puts it, good mental health is a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. So how does one do that in the midst of this pandemic? The answer? We have to improve our emotional resilience. Emotional resilience refers to one's ability to adapt to stressful situations or crises. Those with a higher degree of emotional resilience can handle the stresses that come with daily life more effectively and calmly. A big part of emotional resilience is learning how to identify our feelings, being able to identify and express our feelings. I have put together a 5-step approach to building emotional resilience using evidence-based techniques and interventions. That means these interventions have been proven to be effective. The first step is to become emotionally self-aware. That is to learn how to identify, label, and own your emotions. Best-selling author Dale Holloway puts it nicely. To heal for real, we must feel for real. And to feel for real, we must give ourselves permission to feel our emotions fully. It is surprising how often we act on our emotions before we even realize what the emotions driving the behavior really are. You reach for a drink, or you give your spouse the silent treatment without even recognizing the hurt or the anger that is behind your action. You have to make a conscious choice to be aware of and understand your own emotions, what you are feeling and why, and what you think and do as a result. Research shows that when we label difficult emotions, the amygdala, a brain structure that is part of that mesocortical limbic system that I mentioned earlier and is responsible for registering danger, becomes less active and is less likely to trigger a stress reaction in the body. Secondly, recognizing and understanding your emotions gives you power to control them. While we cannot control the COVID-19 pandemic or life on a whole and all that it brings, once we recognize our fears and anxieties, we can take responsibility for them and decide in a more rational and measured way what to do with the emotions. So step 2 is managing the emotions. Yoga, meditation, and other relaxation techniques all focus on the breath. And there is a brain imaging evidence that breath focus induces a relaxation response and decreases the production of stress hormones in the body. There are different types of meditation. You have to choose the one that works best for you. I'll mention a few. First, we have simple, slow, deep breathing, which helps to disengage from distracting thoughts and sensations. In through the nose, out through the mouth. The next time you feel tense, fearful, or anxious, take several deep breaths and experience relief of your anxiety. Progressive relaxation, on the other hand, releases tension in the body and promotes relaxation through slowly tightening and relaxing one muscle group at a time throughout the body. You can practice this form of meditation just before bedtime to relieve stress and promote sleep. Scientific studies have supported the effectiveness of mindfulness meditation in promoting not just mental health, but physical health. Different grounding techniques like focusing on the breath or visualization improve your ability to pay attention to bodily sensations, thoughts, or feelings as they occur, but without reacting to them. This has been shown to decrease stress, improve coping, reduce anxiety, help with burnout, and enhance learning. Then we have prayerful meditation that seeks a deeper connection with God. In an article entitled Prayer as Medicine, How Much Have We Learned?, researchers concluded that there is a positive association between prayer and improved health outcomes. And on reviewing how people coped after the September 11th tragedy in the United States and after the 2005 subway bombings in London, they concluded that prayer is a successful coping mechanism. So now we have the emotions under control. Step number 3 in our 5-step plan identifies the stress that caused the negative emotions and adopts a realistic approach to managing it. The Serenity Prayer is well known and has a large body of anecdotal evidence to support it. You all must have heard it. The prayer simply says, God, grant me the serenity to accept the things I cannot change, courage to change the things I can, and wisdom to know the difference. When negative emotions are generated by something you have the power to fix or remove, do it. Seek marital counseling for that troubled marriage. But it is not every time that it is possible or practical to remove your stressor. Many times mental ill health arises because people keep trying to do the impossible, especially trying to change others. Your good mental health should never lie in the hands of anyone else but you. Know what you can change and change what you can. Accepting a stressor does not mean that we must continue living with the anxiety and depression that it causes. We can preserve our mental health by adopting a lifestyle of healthy coping. A good place to start is to make an inventory of how you cope currently. We spoke already about unhealthy coping. Is your coping style healthy or unhealthy? If unhealthy, then you would want to adopt some different coping strategies. There are many examples of healthy coping, like simply talking out your stress and expressing how you feel, journaling, getting a pet, doing gardening, reading, listening to music, getting a massage, laughter. It really depends on what works for you. All of these things work. But let's look again at a few healthy coping strategies where the effectiveness is supported by research. Expressing gratitude. Gratitude is a thankful appreciation for what an individual receives, whether tangible or intangible. People who regularly express gratitude for the positive things in their lives have lower rates of stress and depression. There are things that we can be grateful for even during a pandemic. Find them and give thanks for them. In the public survey of the impact of the COVID-19 pandemic in Trinidad and Tobago that I referred to earlier, persons were able to identify positive experiences coming out of the pandemic. More than half of the almost 1,300 respondents of the survey identified more time spent with family, more downtime, the opportunity to learn new skills, more time for hobbies, and better self-care as some of the positive outcomes of the lockdown. One 2021 study stated, cultivating an attitude of mature gratitude through actions of kindness, expressing being thankful for life and God, and enjoying all the small things in life helps in coping with the current threats of COVID-19 and building lifelong resilience for the future. Another proven coping strategy is forgiveness, the letting go of grudges and bitterness. Forgiveness is linked to mental health outcomes such as reduced anxiety, depression, and a reduction in the risk of major psychiatric disorders, as well as with fewer physical health symptoms and lower mortality rates. Let's forgive. And then there's exercise. The scientific evidence shows that regular exercise stimulates the production of natural endorphins, which are natural antidepressants, and improves the sense of well-being. But recent research shows that regular exercise also produces endocannabinoids with the same mind-altering effect in the brain as THC from marijuana without the risk of harm. That's how we get our exercise euphoria. Finally, one of the major challenges posed by the COVID-19 pandemic is isolation and loneliness. Social connectedness has a positive impact on psychological coping. Studies show that people who feel more connected to others have lower levels of anxiety and depression, higher self-esteem, and greater empathy for others. They are more trusting and cooperative, and as a consequence, have healthier relationships. So the final step in this 5-step process to managing emotions and healthy coping, we must make sure that all have social and emotional support, face-to-face or virtually. That means seek help for yourself where needed and be willing to help others when you can.
Much, Dr. Reed, for a very fantastic presentation there, and one that has been very important for persons to understand where we need to go in dealing with our mental health problems during this pandemic. It is a real problem. It's a problem that's affecting many persons. It's now 1:31, and we have come to an end of this program. And I'll just like to thank a few people who made this program possible. Miss Josanne Green, Miss Chelsea Sitahal, Miss Chanel Glasgow, and Miss Wendy Maynard, all from Marketing and Communications, did a fantastic job. Oh, by the way, I didn't forget the 2 tickets to Tobago and the stay at La Grande Colan Hotel. The question is coming up, but I need to thank each and every one of our presenters for taking the time to be here and answering your questions. Starting with Professor Chidum Ezenwaka, the chair of the committee, Professor Terence Mangal, our dean, Professor Brian Copeland, our principal, Ms. Rosette Scotland and Dr. Ucho and that team, Dr. Visha Ramrup, Dr. Jerome Tilak Singh, Dr. Diane Ignacio, Dr. Rian Extavo, Dr. Beryl Simmons, Professor Vijay Narayan Singh, Dr. Parvati Sudas, Professor Yuri Clement, Professor Christopher Ora, Dr. Satish Sakamori, Dr. Sandra Reed. I also have to thank the teams that are currently running those virtual sessions that are taking place. Dr. Sashri Motilal, Dr. Satish Janki, Dr. Siobhan Machan, Dr. Oscar Ocho, Dr. Niall Fanon, and the teams in each of those schools working. All of this that will not happen without the work of the subcommittee run by Professor Eisenwacker, as well as the work done by the vet school, who is having a fantastic program right now with over 285 people logged in, taking in their care for their pets. So just to let you know, that is also something that we'll have recorded and placed outside there. Now to the big question, and this is for the people who have been logged in, stayed with us through the day. They will be getting a voucher. First place will be getting 2 airline tickets to Tobago and a 2-night stay at Le Grand Colan. And the second place person will be getting a voucher from the pharmacy for $300. So here's the question. Dr. Sakamori, in his presentation, it has to be a hard question, right? Said there are 3 stages of COVID. Could you state the 3 stages of COVID and the percentage of incidence of those 3 stages? I shall repeat. The 3 COVID stages and the percentage. How are they categorized? Could one place the 3 stages as well as the categorization of those stages there? And I see people are saying it's a difficult one. It has to be a difficult one. It has to see who has been paying attention along the way. So I leave it in the chat. The person who gets it correct first and who gets it correct second will win a prize. And I can go right ahead and announce the winner immediately because there's no need to go further with this. And you, Ms. Ramdas, you will please send all that information to Ms. Ramdas because I saw someone had already placed the answer in the chat and you have actually won. Ms. Keshmani Singh has answered it correctly and hence you are getting those 2 tickets to Tobago and the stay at Le Grand Colan, followed by Pacheco, Nula Pacheco, who will be getting that gift voucher from the pharmacy. Congratulations to both of you all. We will just look to make sure the attendance is in order. And if not, well, we will then move on to places may switch. But those are the 2 persons who would have got it, and congratulations to you all. Thanks very, very, very much for giving those answers. So we thank you for being with us and ensuring that we had a fantastic fantastic conference, and thanks to all the presenters and to you, the public who has stayed with us. Thank you very much, and thanks to the team. So I'll just ask Mr. Ramdas to stay on a little bit longer to collect that information.